Good evening. So today we are going to discuss the mediastinal surface of the lungs. Okay. So what are the important features present on the mediastinal surface of both lungs? Okay. And bronchopulmonary segments. Okay. Let's talk about these two topics: mediastinal surface of the lungs and bronchopulmonary segments. So first I will be showing you the one image based question. Try to identify the answer for this question. Okay. So the question is identify the structure creating the impression. Okay. Mark have to identify whether the given specimen is right lung or left lung. Then only you can correctly identify the structure creating the impression. Okay. Any idea? Actually, this one is right lung. Okay. I will tell you how to identify the side of the lung. So this is right lung. So this is the hilum of the right lung. The area I am marking now. This is the outline of hilum of right lung. Hilum of right lung. Okay. And this hilum of the right lung is arched by one structure called as azygos vein. Okay. So the answer for this question is arch of azygos vein. Okay. Arch of azygos vein. Okay. So let's talk about the features, external features of both lungs. Okay. Both the lungs will be having anterior border, posterior border, and inferior border. Okay. Inferior border. Fine. The nature of the anterior border is it is thin and sharp. Okay. This is one important feature for identifying determining the side of the lung. Okay. Anterior border, the one I am tracing now. Anterior border is thin and sharp. Okay. Compared to the posterior border. Actually, the posterior border will be blunt. Okay. It is blunt. Fine. And this inferior border, right now I am highlighting the inferior border, which is almost rounded. Okay. Fine. So by looking at the anterior border and posterior border, you can easily identify the side of lung. And it is already mentioned, this is the mediastinal surface of both the lungs. Okay, actually we are seeing the mediastinal surface of both lungs. Obviously it will be facing medially towards the mediastinum. Okay, mediastinal surface of both lungs. And you know, the apex of lungs will be directed upwards, base of lung will be directed downwards. Okay, apex of lung directed upwards. Okay, the base of lung directed downwards. Okay, and it will be resting over the diaphragm. Base will be resting over the diaphragm, so it is called as diaphragmatic surface. Okay. Okay, fine. And as we studied, you know, the apex of lung is directed upwards, base of lung will be directed downwards. Okay, then usually the right lung consists of 3 lobes. Okay. Usually the right lung consists of 3 lobes: upper lobe, middle lobe, okay, middle lobe, upper lobe, middle lobe, and lower lobe. These are the 3 lobes of the right lung, divided by 2 fissures. What are the 2 fissures present in the right lung? Yes, one is oblique fissure, another one is horizontal fissure, isn't it? When we talk about the left lung, okay, when we talk about the left lung, it consists of, usually the left lung consists of 2 lobes, only 2 lobes, separated by only 1 fissure, upper lobe and lower lobe, separated by the oblique fissure. Okay, oblique fissure, isn't it? Okay. So what are the 2 fissures present in the right lung? One is oblique fissure, obviously present in both the lungs. Additionally, we have horizontal fissure, isn't it? Horizontal fissure. Okay. Then one more important thing we have to look here is the anterior border. Okay, the one I am tracing now. Anterior border of the right lung is straight. It is straight or vertical, isn't it? What about the anterior border of the left lung? Yes, the anterior border of the left lung contains one deviation. It contains a deviation called as cardiac notch, isn't it? And just below the cardiac notch, we have one tongue-like projection called as lingula. Okay, this question has been asked. Lingula is present in, okay, lingula is present in which lobe of which lung? Okay, so from the name itself you can easily guess. Okay, from the name itself you can easily guess. Okay, lingula. Okay, L representing the left lobe. Okay, sorry, left lung. Okay, L for left lung, and UL representing the upper lobe of left lung. Upper lobe, UL, upper lobe. Okay, so lingula is a part of upper lobe of left lung. Okay, left lung, upper lobe. Fine. Now, this is the image asked in the first question we have studied actually. Okay, so actually now at least you can try to tell me the side of the lung. Yes, this is the right lung, isn't it? How I am saying this one as right lung? Because what we are seeing is the mediastinal surface. Okay, what we are seeing in this diagram is the mediastinal surface, isn't it? So you can see the anterior border of the right lung, which is thin and sharp. Okay, this is the posterior border of the right lung, which is almost blunt. Okay, then this is the hilum or root of the right lung. Fine, and we know this is the just above the hilum of the right lung, the structure arching will be acygos vein, otherwise called as exactly saying arch of acygos vein. Okay, so the other things we have to keep in mind related to the mediastinal surface of right lung. Okay, other important things related to the mediastinal surface of right lung will be, okay, this is the cardiac impression. Okay, this is the area called as cardiac impression. And remember, the cardiac impression of right lung, in the right lung, the cardiac impression is produced by right atrium chamber. Right atrium chamber produces the cardiac impression. Okay, and obviously just above the right atrium chamber, this impression will be produced by superior vena cava, which opens into the upper part of right atrium, isn't it? And this is the impression produced by the inferior vena cava, which opens into the lower part of the right atrium. And this will be the impression created by right brachiocephalic vein. Okay, and this is the impression created by trachea. And just behind the trachea, this is the impression created by esophagus. Trachea, and this is the impression, this impression is created by esophagus. Okay. So these are the various impressions we have to keep in mind related to the mediastinal surface of right lung. Okay. Cardiac impression produced by right atrium. Just above and just below the cardiac impression, we have the impression produced by SVC and IVC. Then we have the arch of acygos vein just above the hilum of the right lung. Then we have the impressions created by the trachea. Okay, trachea, and just behind the trachea we have the impression created by esophagus. Fine. Then I hope you will be knowing this is the mediastinal surface of the left lung. Okay, this is the mediastinal surface of the left lung. Okay, because this is the anterior border. This is the anterior border of the left lung. This is the posterior border. Okay, so you can easily identify this one as left lung. Okay, mediastinal surface of left lung. Okay, so again, this is the hilum. This is the hilum of the left lung. Okay, and remember the cardiac impression. The cardiac impression on the left lung is produced by the left ventricle chamber. Left ventricle chamber. Okay, so obviously you will be knowing just in the upper part of the left ventricle we have the beginning of ascending aorta. So obviously you will be knowing the ascending aorta continues as arch of aorta. The one I am marking now is arch of aorta, and this arch of aorta continues downwards as descending thoracic aorta. Descending thoracic aorta. Okay, so these are the main impressions on the mediastinal surface of left lung. Cardiac impression produced by left ventricle, Then we have the impression of ascending aorta. The most important one is arch of aorta impression. Arch of aorta. Okay. Arch of aorta. And behind we have the impression created by descending thoracic aorta. Descending thoracic aorta. Okay? And do you see one structure which is hanging downwards from the hilum of both the lungs? In both the lungs, you can see just below the hilum, one structure will be hanging downwards. Okay, it is called as pulmonary ligament. Pulmonary ligament. Okay, pulmonary ligament. So regarding the pulmonary ligament, remember it is a part of. Okay, pulmonary ligament is derived from. Otherwise, we can say it is a part of mediastinal pleura. Okay, it is derived from mediastinal pleura. Okay, fine. Pulmonary ligament is derived from mediastinal pleura. Okay. Yes, let's talk about the bronchopulmonary segments now. Okay, bronchopulmonary segments, BPS. Okay, you will be knowing already. We have studied already the right lung. This is right lung, and this one is left lung, right? So the right lung is divided usually into 3 lobes by 2 fissures. What is the fissure I am marking now? Yes, this is the oblique fissure. This is the oblique fissure, isn't it? And the another fissure I am right now marking is the horizontal fissure, isn't it? Horizontal fissure. So because of the 2 fissures, the right lung is usually divided into 3 lobes. Number 1, upper lobe. This one is upper lobe. Okay, this one has middle lobe, and this one is lower lobe, isn't it? And the 3 lobes of the right lung, they are again subdivided into bronchopulmonary segments. Okay, segments. Lungs are divided into lobes. Lobes are again further subdivided into bronchopulmonary segments. Okay, so how many bronchopulmonary segments are there totally? We have totally 10 bronchopulmonary segments. Okay, totally we have 10 bronchopulmonary segments in each lung, right lung as well as left lung. Okay, fine. See the left lung. In the left lung, there is only one fissure, isn't it? The one I am marking now. What is the fissure I am marking now? Yes, this is the oblique fissure. Okay, so above and below the oblique fissure, we have the upper lobe and the lower lobe, right? Fine. So the 3 lobes of the right lung and the 2 lobes of the left lung, totally they will be consisting of 10 bronchopulmonary segments, right? So what are the names of the bronchopulmonary segments? We have to know, and also we have to know the characteristic features of the bronchopulmonary segments. Okay, so each and every point we are going to discuss now regarding BPS is important. Okay, so bronchopulmonary segment is the part of lung. Okay, it is the part or portion of lung supplied by one segmental bronchus. Bronchopulmonary segment. Okay, it is the part of lung supplied by one segmental bronchus. The another name for the segmental bronchus is tertiary bronchus. Keep in mind. Okay, the another name for the segmental bronchus is tertiary bronchus. So each BPS is supplied by one tertiary bronchus. Okay, so as we studied already, lungs are divided into lobes, isn't it? Lobes are again subdivided into bronchopulmonary segments. What is the shape of bronchopulmonary segment? Pyramidal in shape. Okay, and it is surrounded by connective tissue, which can be called as intersegmental plane. Okay, and the most important point here we have to note here is each BPS has its own artery. Each bronchopulmonary segment has its own artery called as segmental branch of pulmonary artery. Okay, but not own vein. Okay, this is the point. Each BPS has its own artery called as segmental branch of BPS, but not vein. Okay, what do you mean by that? Pulmonary veins, okay, they are intersegmental. They are located in between the adjacent segments. They are not segmental. Pulmonary veins are not segmental. They are intersegmental. And the advantage of the arrangement of bronchopulmonary segments is it is surgically resectable. You can only remove the particular diseased segment. Okay, you need not remove the entire lung, or you need not remove the entire lobe. Whatever segments which are involved in the pathology, that particular diseased segments alone can be removed because of this peculiar arrangement of segments. Okay, they are surgically resectable. Fine. And okay, so take care of this diagram. Okay, take care of this diagram. In this diagram, you are able to see three bronchopulmonary segments. Okay, they have shown three bronchopulmonary segments. These yellow colored structures are the bronchopulmonary segments. Yellow colored structures are the bronchopulmonary segments. Okay, yellow colored structures are the bronchopulmonary segments. Fine. So there are three bronchopulmonary segments. As I told already, okay, each bronchopulmonary segment has its own artery. Okay, this one. Each bronchopulmonary segment has its own artery, which is labeled in this diagram as segmental branch of pulmonary artery, but not vein. But not vein. Do you see the veins in this diagram? Why veins are colored with red? Because pulmonary veins carry oxygenated blood. Why the pulmonary artery is colored with blue? Because pulmonary arteries carry deoxygenated blood. Okay, fine. And you can you see clearly the pulmonary veins or venules, they are intersegmental. They are located in between the adjacent segments. Okay, they are not segmental, they are intersegmental. Okay, arteries are segmental, but pulmonary veins or venules are intersegmental. Okay, and actually one more artery you are able to see in this diagram. It is called as bronchial artery. It is labeled. Okay, it is labeled. So the arteries are segmental, but veins, venules are intersegmental. Okay, and you can see clearly this is the segmental bronchus, otherwise called as tertiary bronchus. Segmental bronchus, otherwise called as tertiary bronchus. Okay. So this also we have to keep in mind. What are the various segments present in various lobes of the right lung and left lung? Okay. So you know, right lung consists of three lobes: upper lobe, middle lobe, lower lobe. So in this diagram, it will be so clear. So what are the three segments present in the upper lobe of the right lung? Do you see the three segments numbered as 1, 2, 3 in this diagram? So apical, anterior, posterior, these are the three segments present in the upper lobe of the right lung. Number one, apical, then anterior, posterior. What about the middle lobe? The middle lobe contains two segments, namely medial and lateral segments. And the lower lobe of the right lung contains five segments: apical, anterior basal, posterior basal, medial basal, lateral basal. That's what in this tabular column we are seeing. Okay, so the upper lobe of the right lung contains three segments. Okay, the middle lobe of the right lung contains two segments, medial and lateral segments. Okay, then lower lobe contains five segments. Apical segment can be otherwise called a superior segment. So one apical and four basal: anterior, posterior, medial, and lateral basal segments. Okay, so upper lobe contains three segments, middle lobe contains two segments, and lower lobe contains five bronchopulmonary segments. Totally 10 segments. Okay. When you talk about the left lung, you know, usually left lung contains two lobes, isn't it? Upper lobe, lower lobe. So in the upper lobe of the left lung, we have five segments. And in the lower lobe of the left lung, also five segments. Okay, so totally 10 segments. Right? So you know, already we have studied lingula is a part of left lung, upper lobe of left lung. So within the lingula, we have two segments. One is superior lingular, another one is inferior lingular segment. Okay, so please try to remember the names of the various segments. Okay, because the question may be the middle lobe of the right lung contains the following two segments. Like that question may be asked. What are the names of the three segments present in the upper lobe of right lung, left lung, like that? Okay. And finally, one important applied aspect of the bronchopulmonary segment is, okay, what is the applied importance of the bronchopulmonary segments? one thing I have told you already. Okay, this peculiar arrangement helps to remove only the particular diseased segment. The procedure, okay, that is bronchopulmonary segments are surgically resectable, isn't it? Then another important point is, can you tell me which is the most common segment, which is the most common bronchopulmonary segment, okay, affected in lung abscess, or otherwise aspiration pneumonia. Okay, the answer for this question is, usually foreign bodies will be entering into the right lung. Okay, so lower lobe of the right lung. Okay, due to gravity, they will enter into the lower lobe of the right lung. Okay, why the foreign bodies usually enter into right lung, you will be knowing, I guess. Okay, because the right main bronchus is shorter. Okay, right main bronchus is shorter, broader, and more vertical. Because of these three main reasons, okay, because of these three main factors, the foreign body usually enters into the right lung, and it will enter into the lower lobe. And the most common segment affected in the lower lobe of the right lung is apical segment. Apical segment. What is the another name for the apical segment? Yes, it is called a superior segment. Okay, so apical segment, otherwise called a superior segment of lower lobe of right lung. Okay, that is the most common segment affected in aspiration pneumonia or lung abscess. Okay, so that's the end of the today's session. Okay, thank you all.
Hello friends, good evening. So today we'll be seeing one interesting question on the poisoning aspect. Okay, yesterday we discussed one interesting question on OPC poisoning and its management. So today we will see another question on poisoning. Let's see. A 30-year-old male, after drinking some locally made alcohol, came with complaints of blurring of vision and rapid breathing on presentation. ABG showed pH of 7.10, bicarb of 10, PO2 of 82, and PCO2 of 23. Sodium was 140, chloride was 90. So here, with this ABG and with this complaint, how are you going to manage this patient? This is the question. First is A, ethanol, B, fomepizole. If not available, then go for ethanol. Or C, the patient needs urgent dialysis plus fomepizole. Or D, steroids. So here you have been provided with the question, a patient having acute emergency presentation after intake of some toxin, which is some locally made alcohol. After that, he was complaining of blurring of vision. And ABG, if you see frankly, grossly, if you see pH is less than 7.35, so acidosis is there. Some toxin is there which is causing acidosis. Metabolic acidosis is there. So with the options itself, you can tell there's nothing but methanol poisoning, methyl alcohol poisoning, because only in that poisoning will be giving ethanol, fomepizole, all those things. But that is not the question. You might find it to be methanol. Okay, but the question is how to treat this patient. Everyone knows ethanol can be given, fomepizole can be given, dialysis can be done. But what is best for this patient? This is the question. Okay, let's see and explore it. First, our basic approach for any ABG, as we have discussed in the previous ABGs also. First is look for your pH. If it is 7.35 to 7.45, it is normal. If it is less than 7.35, it goes towards acidosis. Yes, your pH is 7.10, acidosis. Next is you are going to see the bicarb value or PCO2 value. What is fitting in this? Bicarb is less or PCO2 is more. If bicarb is less than 24, it fits in metabolic acidosis. If PCO2 is more than 40, it fits in respiratory acidosis. Here your bicarb is 10. So it fits in metabolic acidosis. So you have found out the patient is having metabolic acidosis. What is the next step? Step 3. But compensation. Metabolic acidosis means kidney problem. So the compensation will be provided by the lungs. Okay. Metabolism disturbance. So it will be compensated by the lungs. In metabolic acidosis, acid starts to accumulate. So it is expelled by expelling out your carbonic acid as carbon dioxide. Okay. So to expel carbon dioxide, what your lung should do? Increase the respiratory rate and puff out all the carbon dioxide out of the body. So that carbonic acid is driven out of the body. Okay. So your expected PCO2 after correction should be 1.5 times the bicarb plus 8 plus or minus 2. This is Winter's formula. Okay. So 1.5 times 10, which is bicarb, plus 8 plus or minus 2. So 1.5 into 10 will be 15 plus 8, 23. 23 plus or minus 2 means 21 to 25. Okay. Yes. Our PCO2 is 23. So it's nothing but completely compensated ABG they are given for you. Okay. Completely compensated metabolic acidosis. Is the problem ending here? Never. It is metabolic acidosis. you should go on to calculate anion gap as well as delta ratio. These are two important steps you should be doing because INICET exams, there won't be ABGs without the calculation until anion gap and delta ratio. Very easy. Follow the steps. Anion gap is equal to sodium minus chloride plus bicarb. Okay, so sodium is 140 and chloride is 90, bicarb is 10. So 140 minus 100 is approximately 40. Normal anion gap is 8 to 12. Very much increased. High anion gap metabolic acidosis. Good. Next, delta ratio. Delta ratio is equal to change in anion gap by change in bicarb. So the concept is how much ever the extra acid which is added to the body, now it will neutralize the bicarb. How much ever change in anion gap is happening, that much change in bicarb should be there. Okay, if it is more or less, then it suggests some other acid-base disturbance is going on. Okay, so change in anion gap is equal to from the normal anion gap 12, the given value minus 12 by change in bicarb 24, from 24 how much has reduced. Okay, nothing but 40 minus 12 by 24 minus 10. So it is 28 by 14. So anion gap is 2, meaning high anion gap metabolic acidosis only. If it is 1 to 2, it is high anion gap metabolic acidosis only. That is a hard and fast rule you should do. Okay, so how we have found methanol, nothing because only and only due to methanol intoxication. How are you going to treat this patient? So actually, methanol, if you leave it out, it will oxidize and will go into formic acid. This acid will start irritate the optic nerve, causing toxic optic neuritis. And this acid can also accumulate in the kidney and destroy your and can cause acute renal failure to set in. So what to do? We should prevent this oxidation from happening. So to prevent this oxidation, you can be giving ethanol as well as fomepizole. Fomepizole and ethanol are the drugs we can give prevent this oxidation. Okay, but when you should go, and this is like the life-saving procedure in case of methanol poisoning. You won't recognize it until you see a patient lively getting saved by dialysis, because it is like the toxin is there in your blood still. Okay, it can be removed actively by dialysis, and also those toxins which are present now, they will be causing your destruction of optic nerve, blurring of vision will be entirely reversed after dialysis. In complete of blurring of vision, and if the patient is having high anion gap metabolic acidosis, our patient has high anion gap metabolic acidosis, blurring of vision was also there. So if such conditions are there, then that means indication for dialysis. Okay, so here our patient needs urgent dialysis with fomepizole. So option C will be the right option. Okay, thank you for listening. Tomorrow we'll come with one more interesting question.
Okay, so good evening. Today's topic, yesterday we finished CLL. So today's topic will be CML. Okay, so we have finished all the leukemia, lymphomas, then we have finished ALL, we have finished CLL, but SLL. So today we will go into CML, then we'll complete off with, okay, and AML. CML is a very important topic. I need not tell you all that because CML, you know that there are constant questions on CML, okay, in the past 3 years, isn't it? So CML is very, very important. First thing I want you to know, though it is chronic myeloid leukemia, okay, one thing you have to know that under WHO classifications, it comes under myeloproliferative disorders or neoplasms, okay, MPN, myeloproliferative neoplasms. Okay, it comes under myeloproliferative neoplasms. Okay, so one thing apart from this you have to know is it is different from all the, see, in the classification there are 5 things. It includes polycythemia vera, essential thrombocythemia, chronic neutrophilic leukemia. Okay, so these are the important ones. Amongst these, myelofibrosis, yes. So amongst these, how do we differentiate CML from these? What is the main difference, characteristic feature that separates it from these other MPN is that it has constitutively active. See, tyrosine kinase will be active, but constitutively active tyrosine kinase due to BCR-ABL fusion, which produces a protein, okay, tyrosine kinase, which is 210 kilodalton. In ALL, it was 190 kilodalton. That was very effective, isn't it? That was the efficiency was very high. Here it is going to be 210 kilodalton. Fine. So what is the mutation? It is BCR-ABL. Okay. This BCR-ABL is going to drive the proliferation of, it is going to cause proliferation of granulocytes and megakaryocytes. If you observe in all the leukemias, whenever they are giving you history, thrombocytopenia will be there. That is, platelet counts will be reduced, there will be anemia. But in CML, there will be anemia, but they will give you normal or near normal platelet count. That is because BCR-ABL will also help in proliferation of megakaryocytes. Now, this BCR-ABL, how are we going to detect? We are going to detect by FISH or PCR, polymerase chain reaction. Okay, FISH or PCR. Fine. So now what are the clinical features? What are the clinical features of this CML? What are the clinical features of this CML? So one thing, say like how in hairy cell leukemia, I told you about massive splenomegaly. Here also splenomegaly is a very important clinical sign. Okay, there will not be any lymphadenopathy. If the lymph node size is increasing suddenly, brisk increase in lymph node size, it is telling that CML from chronic phase is moving into blast crisis. CML from chronic phase is moving into blast crisis. Okay, the patient will have vague symptoms like he will have fatigue due to anemia, all those things. So when we do he'll be prone to infections. When we do a peripheral smear, okay, when we look into the counts and do a peripheral smear, his total leukocyte count will be more than 1 lakh per cubic millimeter of blood. And there will be increased granulocyte series. Granulocyte series means neutrophils, eosinophils and basophils will be increased. Okay. Exam point of view, lab score, though we don't use it now in the lab, it is an old test. Lab score is reduced in chronic phase, but it is increased in blast phase and accelerated phase. It is reduced in chronic phase. It is increased in blast and accelerated phase. When we do a bone marrow biopsy, we will see that it is hypercellular. The myeloid series will be very cellular. Okay, the proliferation of myeloid series is increased. Okay, and we will see sea blue Gaucher cells. So these findings in the image-based question, I'll show you in the next few images. Okay, apart from that, theoretical part. Okay, apart from that theoretical part, I told you the CML has a chronic phase, it has an accelerated phase, and it has a blast crisis. Now, this is an important exam section. Okay, so in chronic phase, the blasts in the bone marrow and the peripheral smear will be less than 10%. Okay, the patient will show BCR ABL translocation, 922 translocation. The pathology, I'll tell you. Okay, fine. That is one thing. Next, in the accelerated phase, the blast count will be around 10 to 19%. There will be basophilia, more than 20% basophils. Okay, usually in an image-based question, if they focus a basophil, you have to think of CML. Okay, the patient will, in accelerated phase, can have thrombocytosis or penia, thrombocytopenia, but that will not respond to any treatment. Okay, non-responsive to treatment. That is one point. Okay, then the patient will have leukocytosis or splenomegaly, non-responsive to treatment. Okay, in blast phase, the blasts count is more than 20%. Okay, and you will see these blasts in form of large clusters on bone marrow biopsy. Paratrabecular area, you will see large clusters of these blasts. Okay, extramedullary, that is outside the bone marrow, in some tissues, when you see accumulation of blasts, that is called chloroma, eye orbit. Okay, so this is the theoretical part of this. Right, now coming to the Philadelphia chromosome. When it comes to Philadelphia chromosome, what is this Philadelphia chromosome? That is important, isn't it? So see, there is reciprocal translocation of 922 chromosome involving the 922 chromosome. Okay, so this ABL gene, which is present on the long arm of 9Q, okay, when this ABL gene, okay, is translocated to the long arm of chromosome number 22, okay, then that chromosome 22 where BCR gene adjacent to the BCR gene, okay, ABL gene will be translocated, and when this chromosome 22 contains this ABL BCR ABL in the long arm, that chromosome is called Philadelphia chromosome. So the 22nd chromosome is the Philadelphia chromosome. When BCR and ABL are adjacent to each other, they produce a protein tyrosine kinase, which is constitutively active. Okay, this is about Philadelphia chromosome. So ABL is present on 9th chromosome on long arm. BCR is present on 22nd chromosome on long arm. The ABL is translocated adjacent to the BCR. Okay. So this is the peripheral smear of CML. How to find out it's a CML? See, when it comes to the myeloid series, granulocytic series, what happens in myeloid granulocytes? First, we have myeloblast. Okay, then we have. So how this myeloblast looks? These are larger cells. Okay, they have high NC ratio. They have fine lacy chromatin with prominent nucleoli. This is a myeloblast. 1 minute. There's no myeloblast in this image. Okay, so this is a myeloblast. Fine. Then next, after myeloblast, there will be promyelocyte. So promyelocytes, it will be a little larger than the myeloblast. Okay, the nucleus will be little shrunken. Okay, there will be 1 or 2 nucleoli. What is important is they will have granules. They will have granules. That is promyelocyte. Okay, after that, this will develop to myelocyte. Myelocyte, this cell is little smaller than promyelocyte, but they will have D-shaped nucleus characteristically, no nucleoli, and they will have granules. Okay, they will have granules. This is a myelocyte. They will have granules. This is a promyelocyte, this is a myelocyte. Then we have metamyelocyte. In metamyelocyte, what happens? It is similar to a myelocyte, but there is a small indentation in the nucleus. That is metamyelocyte. This is a metamyelocyte. Then we have something called band forms. Band form is this indentation of the nucleus deepens. So these all have granules. The indentation deepens. Okay, and this band form later will give rise. This is also a band form. This is a nice band form. Okay, this will later give rise to segmented neutrophils. Okay, so you will see the spectrum of these cells. So you will see a promyelocyte, you will see a myelocyte, you will see a metamyelocyte, you will see band forms, you will see. So all the precursors you will see segmented neutrophils. Along with that, you will see basophils and eosinophils also. Okay, and platelets will look adequate. So when you see this, see in CLL, I told you there are uniform small cells, isn't it? School uniform like. Here, they're different stages. So college girl appearance, colorful. Fine. That is how you have to remember. It's a well-known mnemonic. Fine. So this is a smear of chronic phase of CML. Fine. Okay. So after this, before, see, these are blast. These are blast. In that there was no image with blast. So these are blasts. In acute phase, you will see many blasts. Blast phase, you will see many blasts. Blast phase or accelerated phase, you will see many blasts. Okay. So this is showing blasts. Fine. So prognostic index, how to determine the prognosis, there are 2 types of indices, Sokal index and Hasford index. Okay, so what are the criteria they use is an MCQ for you all. What are the criteria they use is an MCQ. First thing is age in both, platelet count in both, spleen size in both, okay, and blast count in both, circulating blast count in both. But Sokal is recent, so it utilizes cytogenetics. Hasford utilizes basophil count. Okay, age, pH, spleen, and circulating blast. Along with that, in case of Sokal, it is cytogenetics, and in case of Hasford, it is basophil count. Fine. So what is the treatment for it? Treatment for it is imatinib. Treatment for it is imatinib. Okay. So here, protein kinase inhibitor, the imatinib site is, it is going to bind where ATP had to bind. So treatment is imatinib. Okay, fine. Thank you. That brings us to the end of CML. Thank you.
Good evening. We'll start some important topic discussion in microbiology, which can be a probable upcoming your exam questions. So we'll start with nosocomial infection. So definition of nosocomial infection has been asked in the past. So this can be a probable your entrance test question. So how you define nosocomial infection? So nosocomial, nosus means disease, comian is to take care of. Okay. So what is nosocomial? Nothing but hospital acquired infection. Other name is nosocomial infection or healthcare associated infection. Anything can be, any term can be used for this. So infection which happens, which occurs after 48 hours of admission, which was not present in its incubation period at the time of admission. Okay, happens after 48 hours of incubation and or within 30 days after discharge. That is called nosocomial infection. Okay, so duration of nosocomial infection 48 hours are inpatients and after within 30 days of discharge is termed as nosocomial infection. So what are the transmission? Various mode of transmission is there: contact, vector-borne, airborne, droplet, vehicle. So source of hand of healthcare worker is one of the common source of healthcare associated infection. Whether it's your MRSA, methicillin resistant Staphylococcus aureus infection, okay, so these all are very common, vancomycin resistant enterococci. These all are common healthcare associated infection or multi-drug resistant organism. So we have to maintain the hand hygiene, which will reduce the nosocomial infection a lot. So hand hygiene or frequent hand washing is very important to decrease the rate of nosocomial infection. So what are the nosocomial infection? So we have surgical wound, post-op surgical wound infection, pneumonia, ventilator associated pneumonia, IV catheter associated infection, urinary catheters, different type of nosocomial infections are there. So surgical wound, we have Staphylococcus aureus, Escherichia coli, and Streptococcus or Enterococcus fecalis. Okay. So Staphylococcus aureus is considered to be one of the most common cause of nosocomial infection. Then in pneumonia, you have Klebsiella pneumoniae, Pseudomonas aeruginosa. Then you have few GPC like Staphylococcus and Enterococcus. Then catheter, you have Staphylococcus epidermidis, because epidermidis is present as a normal flora on the skin. Then you have Staphylococcus aureus, then you have Enterococcus fecalis, candida. This can be IV catheter associated infection. Then urinary catheter, most common cause of UTI, that is your Escherichia coli. Then Enterococcus fecalis, Pseudomonas aeruginosa, Klebsiella species can be a cause of UTI. So these are different causes of UTI. So which organism, question can be asked, which of the above given organism can be a cause of UTI? So you have seen in this Staphylococcus aureus, Staphylococcus epidermidis, Escherichia coli, Klebsiella, Pseudomonas. These are, and Acinetobacter. These are the common cause of nosocomial infection. Okay. So as we discussed, most common cause is Staphylococcus aureus, which has been asked in your entrance. Apart from that, you have Escherichia coli, Enterococci, Candida. And causes we discuss: urinary catheter, surgical site infections, central venous catheter or peripheral lines, then mechanical ventilation, that is ventilator associated pneumonia. What is the preventive measures? Frequent hand washing, as we discussed, will reduce the nosocomial infection. Then appropriate antimicrobial use, routine disinfection, and removal or lesser use of indwelling devices as much as possible. Okay. Now coming to next topic. Okay. What are the normal flora? What are the normal flora of skin and various other sites? Okay. So you have normal flora in the nose. Okay. Normal flora which is normally present there. Okay. So you have in the nose, Staphylococcus is there, Haemophilus is there, Neisseria, Streptococcus. These are the normal flora of the nose. Okay. Then skin, you have Staphylococcus, Bacillus, Propionibacterium, Candida, and Streptococcus. So this has been asked previously. What are the normal skin flora? Okay. So answer must be out of these. Okay. Then in the mouth, which all are normal flora, you have Fusobacterium, Staphylococcus, Streptococcus, Candida, Haemophilus, Actinomyces. Then small intestine, you have Bifidobacterium, Enterobacteriaceae group, Clostridium difficile, then Enterococci, Bacteroids, Lactobacillus. These all are normal flora in smaller intestine. Then vaginal tract, you have Candida, Gardnerella, Lactobacillus, Peptostreptococci. These all will be present in urinary tract. Okay. Then in the rectum, you have diphtheroids, bacteroids, Peptostreptococci. Okay. Colon, you have Escherichia coli, Proteus, Klebsiella, Pseudomonas. These all are normal flora in your colon. So you have to remember the normal flora of every part. Okay. Now coming to sexually transmitted diseases. Okay. So a few questions which has been asked previously on sexually transmitted diseases on donovanosis. Okay, donovanosis or granuloma inguinale, which is a sexually transmitted disease. And okay, so how it will look, you will have safety pin appearance of the organism, which is called Donovan bodies. This will be inside the macrophages. Okay, and what staining you are going to use for this is Wright or Giemsa stain. So question was given like this: organism showing safety pin, patient presenting with genital ulcer, and the staining shows safety pin appearance, and it was the organism was seen inside the macrophages or phagocytic cell, and Wright and Giemsa stain was performed to visualize the specimen. So your answer should be donovanosis. Okay, now coming to chlamydia trachomatis, we have discussed chlamydia chapter in detail. Now restricting itself to the sexually transmitted disease. Okay, so this is one of the common cause of non-gonococcal urethritis. Very important, non-gonococcal urethritis, chlamydia trachomatis. Okay. So how the male patients will present? They will present with grayish white discharge, and urethritis will be the presenting feature. How the female patient will present? Which vaginal discharge or bleeding, cervicitis or pelvic inflammatory diseases will be the presenting feature. Okay. Repeated infection of chlamydia trachomatis can lead to infertility. Okay. So you can see in the picture, this organism will be very small, intracellular organism. So you get a question like this: most common cause of non-gonococcal urethritis, chlamydia trachomatis. Then the patient presenting with male patient presenting with urethritis and white discharge, and gram stain was performed, which could not visualize the bacteria. So you might not be able to visualize because they are mostly intracellular organism, and it can lead to infertility. Okay. And apart from this, donovanosis and chlamydia trachomatis, non-gonococcal urethritis, we have discussed other sexually transmitted disease in the respective chapter, like syphilis and others, okay, which is caused by Treponema pallidum. We have discussed that in detail. Thank you. So we complete the topic for today.
So hello, we'll start and we'll finish the topic where we started yesterday. So yesterday we were discussing about C6, C7 fractures, right? So I told you about an antemortem and postmortem C6, C7 fracture. This one is an antemortem C6, C7 fracture due to submental knot hanging. C6, C7 fracture due to submental knot hanging, right? So due to submental knot, right? Submental knot hanging. So you could look at the hemorrhages around the fractured site, right? The hemorrhage, the amount of extravascular blood, right? So compare this with the photo. And the photo is clear, right? The field is clear. There is no bleeding, right? So this is a postmortem fracture, right? Undertaker's fracture due to rough handling of the body. Undertaker's fracture, right? Okay. So we'll continue with hanging. So this is one of the repeat Jipmer question. And the question is, you could see here a white line, right? A white line. This is nothing but dried salivary stain, right? Dried salivary stain. Okay. Oh, excuse me. So dried salivary stain, right? So the ligature stimulates the salivary ganglia, and there will be salivation. The dribbled saliva will dry itself, so it will form dried salivary stain pattern. Now, this dried salivary pattern is one of the key findings to say a hanging is an antemortem hanging, right? Antemortem hanging. So, antemortem signs to say that a particular person is died of hanging is antemortem sign of hanging is dried salivary stain, right? Dried salivary stain. One more antemortem finding is there for hanging, that is leafachy sympathetic, right? Leafachy sympathetic, which is nothing but, you could see here, partly opened eyelid with dilated pupil. So partly opened eyelid, right? Open eyelid, and then dilated pupil, right? Dilated pupil. Now this is also an antemortem sign for hanging. Now this antemortem sign, the leafachy sympathetic, you cannot commonly encounter during autopsy, right? Because after death, both pupils will go for dilatation. So it is not easy to document this finding in postmortem. So whereas the dried salivary stain is more commonly encountered, right? So antemortem findings to say hanging is dried salivary stain and leafachy sympathetic. Okay. So which one is more relevant or reliable? Dried salivary stain, right? Dried salivary stain. Okay. Now other findings with respect to hanging, right? Other findings with respect to hanging, you could see seminal discharge, right? Seminal emission. Seminal emission is possible with respect to hanging. Is possible, right? Seminal emission is possible, but it is not a sure sign of hanging. Remember, seminal emission can be due to any asphyxia of any means. It need not be hanging. Asphyxia of any means can give rise to seminal emission. But in hanging, seminal emission is more common, right? More common. Right? Okay. Then glove and stocking pattern. Glove and stocking pattern of liver, that is postmortem hypostasis, will be glove and stocking pattern. So I tell you again, glove and stocking pattern of liver mortis is possible with hanging as well as drowning. So both hanging and drowning deaths will have glove and stocking pattern of liver mortis or postmortem hypostasis, right? Okay. So we'll go for the next topic, that is strangulation, right? Strangulation. So hanging we have completed. Then we'll go for strangulation. The strangulation is of three types. One is manual strangulation, right? Manual strangulation. Manual strangulation is nothing but throttling, right? Throttling. Throttling is otherwise called as manual strangulation. Throttling is otherwise called as manual strangulation. So what other kinds of strangulation are there? So one is ligature strangulation, using a ligature, a rope or a wire, right? Ligature strangulation. Then third one is palmar strangulation, using palm to strangulate a person. So palmar strangulation is possible against children. Against children, palmar strangulation is possible, right? So manual strangulation or throttling is possible against adult, right? Adult. Okay. Now this ligature strangulation, three types of strangulation. So I'll tell you again, one is ligature strangulation, second is manual strangulation or throttling, third one is palmar strangulation. Okay. Now if the ligature strangulation uses a thin wire, you see a thin wire, it is called cheese cutter method. It is called cheese cutter method. Cheese cutter method of strangulation, a thin wire, right? Okay. So in general, strangulation ligature mark will be soft in nature, soft, and the ligature mark will be, see, the horizontal ligature mark, horizontal and complete ligature. So horizontal complete ligature strangulation, incomplete and oblique hanging, right? And another important point with respect to strangulation is soft tissues of neck will be contused. So as a dictum, mechanical asphyxia deaths during autopsy, neck should be dissected at the last. So head should be opened first. So starting from here, thorax and abdomen opened second. So neck is dissected at the last. Okay, if we go for bloodless dissection of neck or last dissection of neck in a suspected mechanical asphyxia case, soft tissues of neck will have contusion. Then the cause of death is strangulation, right? Strangulation. So soft tissues of neck is clean. Cause of death is hanging, right? Okay, so I'll tell you again, 3 types of strangulation are there: ligature strangulation, palmar strangulation, manual strangulation or throttling. Palmar strangulation is possible against children. Manual strangulation, throttling against adult. Okay. Now, if you go for bloodless dissection of neck, strangulation shows extravasated blood. Okay. Now, in the picture, you could see horizontal complete ligature mark due to a thin wire, a slender wire. It is called cheese cutter technique. Okay. Now, other 2 relevant findings are bulla on the lungs, emphysematous bulla on surface of lungs, right? Emphysematous bulla on the surface of lung, and passing of feces is common with strangulation. So there was a repeat question, that is, seminal emission is common with hanging, right? Defecation is common with strangulation, right? Strangulation. Okay. So another image-based question, right? Image-based question. The first image we already know from the previous topics we discussed. You could see small contusions or bruit. Visible contusion is bruit, right? Small visible contusion due to fingertips, pressure due to fingertips. Now this is throttling. The 6-penny bruit, or is called as 6-penny bruit. This is attempted throttling. Now, these 2 images are given in the MCQ. Please remember, the fingertip contusion or fingertip bruit on the neck is attempted throttling. Okay. Now what is this cartilage? This cartilage is nothing but cricoid cartilage, right? Cricoid cartilage. Now there is a line in every textbook of forensic medicine which goes in this way. Cricoid cartilage fracture is exclusive for throttling, right? Exclusive for throttling. If you see cricoid cartilage fracture, the cause of death is throttling until it would arise, right? So this is a repeat MCQ question. So contusion on the neck, right? Fingertip contusion on the neck associated with the cricoid cartilage fracture, throttling or manual strangulation. Then other types of strangulations, right? Other type of strangulation. You could see this is called mugging, right? Mugging. So sudden attack from behind and holding neck of an individual with bend of elbow. Now you are strangulating neck of a person with elbow, right? This is mugging. So attack from behind, strangulating neck of the victim with bend of elbow. It is called a mugging, right? Mugging. Now what is this? This is windlass, Spanish windlass. This is called garroting. That is called as Spanish windlass technique. Spanish windlass, right? Spanish windlass technique. Oh, this was in old times. This was a method of execution in Spain. So it is called a Spanish windlass technique. So what is here? So this is also attack from behind, but the difference is there will be a constricting force or a lever. So if you tighten the levers, these levers, the constriction of the neck will tighten, right? So there will be a twisting force at the back of neck, a twisting force, right? So mugging plus a twisting force is nothing but garroting, right? So mugging is just attack from behind with the bend of elbow, mugging. So sudden attack from behind, and there is a twisting force at the back of neck, garroting, right? Garroting. The next slide. And so please pay attention. You could see small hemorrhages here, aberrated contusions here, right? So the distribution of aberrated contusions, right? You could say this is smothering, death due to smothering, right? So yesterday we saw what is smothering. Smothering is nothing but occlusion of external respiratory orifices, that is nose and mouth. So if you occlude nose and mouth, this is smothering, right? Smothering. So occlusion of nose and mouth, the external respiratory orifice, smothering, right? So associated findings will be frenulum tear, right? Inside, if we avert the lips, there could be frenulum tear, right? Frenulum tear in the upper lip or lower lip, frenulum tear, associated findings for smothering. Now suppose instead of occluding the nostrils and mouth with hands, if you are occluding with hands, there will be possibility of aberration or contusion, right? So if a person or the assailant puts a plastic bag over the victim's head, plastic bag asphyxia. So if a plastic bag is put around the head and it is tied around the neck, plastic bag, it is called plastic bag asphyxia. Now plastic bag asphyxia is also smothering, right? The mechanism is smothering. So remember, plastic bag asphyxia, right? Plastic bag asphyxia. This was an old MCQ question that is about plastic bag asphyxia. So putting a plastic bag around the neck and tightening it will cause death by impact, smothering, right? Smothering. Because if you are making a plastic bag around the face, so you are indirectly occluding the gaseous exchange from the external side. So we are occluding the nose and mouth, right? Smothering, right? So this one is choking. You could see a toy, a balloon occluding the vocal cords, right? Occluding the vocal cords, right? So this is choking. Choking. So mechanical occlusion from the level of vocal cords till the level of bifurcation of trachea is called choking. Now, this choking, if it is by edible substances, food, for example, is called cafe coronary. Right, food, cafe coronary. If it is due to toys, as happens in this case, toys, it is called creche coronary. Because creche is a place where we leave the infants or toddlers for taking care of, right? The creche. So there, the infants or the toddlers would swallow whatever that they toys. The choking substance will be a toy in toddlers or in children, right? Now it is due to food in adult, it is cafe coronary, more common in intoxicated individuals, right? Intoxicated individuals. In intoxicated state, choking is more common. Now, what causes death in choking? Ventricular fibrillation or vagal inhibition. VFib or vagal shock causes death even before this choking material could have completely occlude the gaseous exchange. So this balloon or toy or food particle would occlude the respiratory tract. Yes. So because before a complete occlusion, so this substance will irritate the laryngeal mucosa. So this will indirectly stimulate vagus. So there would be vagal inhibition or ventricular fibrillation that could cause death before complete mechanical asphyxia could occur in choking, right? So now, this is another repeat MCQ area. You could see the occlusion pressure of the neck. So if we apply 2 kg pressure on the neck, jugular vein will get occluded. so sensitive structure for pressure over the neck, jugular vein, highly sensitive. Just 2 kg pressure, jugular vein will go for occlusion. Whereas carotid, we need 5 kg. So 5 kg occlusion will cause carotid occlusion. So please remember, that is why the most common cause for death in hanging is cerebral congestion and anemia, right? Because even with slightest pressure, the jugular vein will get occluded, all right? So jugular 2 kg, carotid 5 kg, and trachea and thyroid cartilage, similar number, 15 kg. So trachea will get occluded or compressed, and thyroid cartilage can go for fracture with 15 kg pressure on the neck. Okay. Now, cricoid cartilage fracture, the throttling cricoid cartilage fracture needs at least 20 kg pressure, right? At least 20 kg pressure for occlusion as well as fracture. Then vertebral artery. The vertebral artery is more inner, right? More inner, and we need approximately 25 kg of pressure over the neck to occlude vertebral artery, right? Vertebral artery. So highly sensitive is jugular, highly sensitive. Least sensitive or more pressure is required for vertebral artery, right? Vertebral artery. So repeat MCQ is jugular and carotid. Jugular and carotid are the most number of repeats, right? So 2 kg and 5 kg occlusion pressure will occlude these following structures, right? So now we have come to the end of today's presentation and the mechanical aspects here. Thank you.
Good evening, everyone. Yeah, is the video seen? Okay. So today we'll be discussing another important topic. We'll be discussing about the important intraocular lenses. Okay. So yeah. Is it seen? Is the screen seen clearly? Yeah. Yeah. So importantly, we'll be discussing about the types of the intraocular lenses today, and also a few points about the various lasers, their frequency, and the uses of various lasers. Okay. First, coming to the intraocular lenses. Okay. So before that, yeah. So what are these type of lenses? These are the anterior chamber IOLs. Okay. These are the AC IOLs or the just a minute. These are the AC IOLs or the anterior chamber IOLs. Okay. So one question they can ask you, one potential question they can ask you is which is the configuration which is correct. Okay. So this we can see that it is an inverted Z. Well, this is the normal Z configuration. Always remember the normal Z configuration is the one which is used for ACIOL implantation. Okay, the normal Z configuration is used for ACIOL implantation. With ACIOL, the important side effects you should remember is the UGH syndrome. What is UGH syndrome? UGH syndrome stands for uveitis glaucoma hyphema syndrome. Okay, so these lenses we have to size the lenses based on the patient's wide to wide diameter. Okay, based on the patient's wide to wide diameter, we have to size the intraocular lenses. These lenses, every time the pupil constricts and dilates, there is chafing of the iris pigments. The chafing of the iris pigment is responsible for the uveitis in these patients. And also the raised, the pigments can go and block the trabecular meshwork, resulting in glaucoma. And because of the constant friction between the peripheral part of the lens and the iris, there is hyphema in these patients. So this is the UGH syndrome, which is another important complication of ACIOL. Okay, ACIOL, we have to remember, we have to size the lenses correctly, and we have to place them in the Z configuration. So when they are put in the anterior chamber, they have to be placed in the Z configuration. Okay, and a peripheral iridectomy has to be performed. So this lens, so you can see the typical marking present here. Okay, so this marking is nothing but the toric lens. Okay, this is your toric lenses. So when do you use toric lenses? So toric lenses typically are used when the dioptric power of the patient is more than 1 diopter cylinder. Okay, and the cylinder lenses, the toric lenses, again the toric calculator. Each company comes with a toric calculator. So the toric calculator helps in aligning the lenses. Okay, based on the, so once we place the lens number in the toric calculator, we'll get the alignment of the lenses. So these marks have to be aligned along the axis in which the toric calculator is indicating. Okay, so these, when you see these 3 dots, it indicates a toric intraocular lens. So next you see multiple rings. So whenever you see a multiple rings, it is your multifocal intraocular lens. Okay, multifocal lenses, we have the diffractive type of intraocular lens and the refractive type of intraocular lens. The refractive types are the older ones. Okay, the refractive types are the older ones. So nowadays we don't use a lens called as rezoom was one of the older refractive lenses which were commonly used earlier. Now we have completely shifted to diffractive intraocular lenses. Okay, so this is a 3-piece IOL. When do you use a 3-piece IOL? So remember, the 3-piece IOL is usually used whenever the patient has a weak capsular bag, or when the patient has a posterior capsular rupture, or the patient has a zonular dialysis. So whenever the patient has a posterior capsular rupture or patient has a zonular dialysis, when the capsular bag is weak, when we cannot put a normal lens in the capsular bag, we put in a posterior capsular, we put in a 3-piece intraocular lenses. Okay, 3-piece intraocular lenses. So this, so here we can see multiple things. Okay, these are the plate haptic IOLs. Okay, so till now, this is the first plate haptic IOL we have seen. Second thing, you can see there are multiple rings. Okay, there are multiple rings from the center to the periphery. Okay, so this is a trifocal lens, not a multifocal. It is a trifocal lens, and you can see the toric markings. Okay, so this is a toric trifocal lens. Okay, so the only company which produces this toric trifocal is the Zeiss. Okay, this is a Zeiss toric trifocal IOL. See, whenever you're placing a plate haptic IOL, always remember the size of the capsular axis should be more than 5.5 millimeter. Okay, so whenever you're placing in a plate haptic IOL, the size of the intracapsular axis should be more than 5.5 millimeter. So next, these lenses are nothing but the iris claw or the iris clip lens. So the iris claw or iris clip lens are again used when the capsular support is very weak, when the capsular bag has fully come out. So we can clip the lenses to the iris. Okay, so we have to be very careful, because if we excessively press over this area, the haptics can get cut. Okay, and also over enclavation can also result in holing of the iris. Okay, there can be a holing of the iris because of the over enclavation of these while using these lenses. Okay, these are the iris claw or iris clip lens. These are the older lenses which are known as the artisan lenses. So artisan lenses were earlier used for correction of very high myopia. Okay, almost -12, -13, -15 also were corrected with these artisan lenses. But now with the advent of the ICLs or your implantable Collamer lenses, these lenses are rarely used. Okay, so this is the accommodative IOL. So this is the Crystal lens, which was described by Bausch & Lomb company. So this is an accommodative lens. Okay, so this is one of the lenses used for presbyopia correction. Okay, so like your natural crystalline lens, like how these zonules will contract, resulting in the ciliary body relaxation, thereby increasing the anterior curvature of the lens. These lenses also increased in the anterior curvature, thereby helping in accommodation. But these are not very famous. Okay, because they are not that effective. Okay, in correcting presbyopia. So this you should remember is a sulcus fixated intraocular lens. Okay, sulcus fixated intraocular lens are again used when the capsular support is weak, when the capsular bag is not there, there's vitreous prolapse in the anterior chamber. So we'll have to do a vitrectomy, and then we can suture these lenses to the sclera. Okay, so these are scleral fixated IOL. So these holes here are for the 2-point or 4-point fixation. So we either do a 2 or a 4-point scleral fixation. So what it means that if only 2 points are used for the scleral fixation, it is known as the 2-point fixation. When 4 points are used for scleral fixation, it is known as 4-point scleral fixation. These are the sulcus fixated intraocular lenses. Next, these are the telescopic lenses. Okay, so telescopic lenses are used for patients with macular dystrophy, macular degeneration, age-related macular degeneration, macular pathology. So they typically act by magnifying the image for the patient. So whatever the patient is able to see, it is a magnified image. Okay, compared to a normal patient. These are also newer lenses. Okay, so these are one of the newer lenses known as the telescopic lenses. Okay, telescopic lens. So next, we have the Morcher's lenses. These are the capsular fixated lenses. So these part come over the anterior capsule. So these maintain the effective lens position. So what happens is each time the pupil dilates and constricts, whenever the lens goes front and back, the effective lens position remains constant. With these lenses, the effective lens position remains constant. These are the Morcher's lenses. Okay, these are the capsular fixated lenses. Okay, so we should also know about the various supports for the weak bag. Whenever we have a weak capsular bag, so we can use various modalities for supporting the weak bag. One is the traditional CTR. Okay, whenever this is the traditional CTR, again the CTR has to be sized based on the patient's white to white. Okay, patient's white to white. And this is the modified CTR, also known as the Sione's ring. Okay, it helps in stabilizing the bag. In addition to that, this point is for the scleral fixation. This is for the scleral fixation. So the CTS is typically used when there is a weak. CTS is typically used when there is a localized zonular weakness. Okay, when there is a localized zonular weakness. Okay, localized zonular weakness, we usually use a CTS or a capsular tension segment. CTR is used when there is a generalized zonular weakness, like a pseudo exfoliation. Okay, if the patient has pseudo exfoliation, we can use a traditional CTR. Okay, if the generalized pseudo exfoliation is associated with a localized zonular weakness, like for example, the patient has 3 or 4 clock hours of zonular weakness, we can put in a Sionese ring. The scleral fixation, it has a point for the scleral fixation, so it remains more stable. For localized zonular weakness, we can use a capsular tension segment, also known as the CTS. Okay, so we should also know a few pupillary expansion devices. The first one is the Bhattacharya ring or the B-hex ring. So it is available as the hexagonal design or a square design. The hexagonal one is the more commonly used. So it gives a pupillary size of about 5.5 to 6 millimeters. So which is adequate for performing a phacoemulsification. Okay, even in hard cataracts, it is decent enough to perform a good phacoemulsification. Next is the eye ring. Okay, this also is made up of PMMA, which is used for pupillary expansion. So this is how it appears. Okay, this is the pupil which is dilated with the eye ring. Okay, next is your Malyugin ring. So Malyugin ring, again, it has an injector through which the iris is, the pupil is expanded. Okay, the Malyugin ring is one of the commonly used pupil expanders. Okay, so this is the ASIS. Okay, this is the ASIS support. Okay, so what it does is it provides a localized capsular support, and these points are for scleral fixation. So it provides a 2-point scleral fixation along with the localized capsular support. Okay. Okay, quickly we'll go to the questions. An infant, how much time we have? Okay, an infant presents with bilateral white pupillary reflex on slit lamp, a zone of opacity. Most likely diagnosis is, okay. So what I tell you, in a zonular cataract, the patient typically the fetal nucleus is involved. These radial opacities, spoke-like radial opacities, are nothing but the riders. So the other name for the zonular cataract is lamellar cataract. So another important point I told you, it is autosomal dominant and associated with hypocalcemia. So it is autosomal dominant associated with hypocalcemia, presence of involvement of the fetal nucleus along with cortical riders, which are characteristic of zonular cataract. Okay, so modern IOL. So this is a PGA question. So what are the materials which are commonly used for modern IOLs? Remember, acrylic we use, PMMA we use silicon. Earliest IOL described by Harold Ridley. Okay, now we don't use. Okay, see, remember the incidence of PCO is least with hydrophobic acrylic lens. Okay, hydrophobic acrylic lens, the incidence of PCO is least. Okay, the silicon lenses, the heparin coated. See, again, remember, heparin coated lenses can be used in patients with uveitis. Okay, coated lenses for uveitis patients. So this is important, this one. Okay, so with this, we'll finish the class for today. Okay, the lasers, a few points quickly about the lasers. Okay, so lasers, we should know the wavelength of the lasers. First is the Nd:YAG laser. Okay, so Nd:YAG laser, the wavelength is 1053 nanometers. So Nd:YAG laser, as we know, is used for YAG capsulotomy, YAG iridotomy. It is based on the principle of photo disruption. The next is the double frequency Nd:YAG laser. So double frequency, the wavelength is 532 nanometers. This is 1054, 532 nanometers. Double frequency Nd:YAG laser. Okay. Next, we should know the excimer laser. Okay. Double frequency Nd:YAG laser is typically used for SLT. It is used for SLT. Again, it is based on the principle of photocoagulation. Next is the excimer laser. Excimer laser, the wavelength is 193 nanometer. The excimer laser is based on the photoablation. Okay, it is based on the principle of photoablation. It is green laser is a 514 nanometer or a 532 nanometer based on the principle of photocoagulation. Okay, and is used for PRP. The last laser is the femtosecond laser. The femtosecond laser, the wavelength is 1052. The femtosecond laser, 1053. It can be used for nanometer. Nanometer. So it can be used for relax smile. It can be used for femtosecond cataract procedure. It can be used for flex. What is flex? Femtosecond associated lenticule extraction along with SMILE. Okay, relax SMILE stands for small incision lenticule extraction. So the all femtosecond laser Vizumab is an all femtosecond laser which is used for relax SMILE. Okay, the name of the laser is Vizumax, all femtosecond laser. Okay, so with this we will finish the class for today. So all these are very important points from the exam point of view.
So here we are today going to finish all the other small miscellaneous things in the physiological changes in pregnancy. So we have done with all the major systems, and it is now time for us to start with the renal change and the hepatic gastrointestinal changes and other small changes. So we'll go directly to the topic. So we have here some questions which we will read before we go into the topic proper. Which of the following statement is false? Like, this question is mainly aimed at asking you the amount of iron that is required. Okay, so it is aimed at asking the amount of iron that is required for the mother to improve her RBC stores, how much of iron is needed by the fetus to improve the, for the formation of blood, how much is the increase in cardiac output, how much is the increase in BMR, basal metabolic rate. So it's a combination question. Question number 2 is something to deal with the renal change, something about the glomerular filtration rate, but the question specifically targets the effect of preeclampsia on GFR. Okay, so we'll study that also. Number 3, we have a combination question of proteins, 1 point from the respiratory system, 1 point from the cardiovascular system, 1 point from the renal system, and the other from the total protein. So it's a combination question. Fine. So to sum up, so first we will start with the kidneys and the ureter. We are starting with the urological system. Now, kidneys, the size of the kidneys itself is said to increase by 1 centimeter. Is it okay? And now the glomerular filtration rate increases because of the increase in renal blood flow. So there is an increase in the renal blood flow. Now this leads to an increase in the glomerular filtration rate. Now when we take glomerular filtration rate, it starts increasing by even second week of conception. Okay, it starts increasing even by second week of conception. And you can see that the increase in the in the second and the third trimesters, it's around 50%. So nearly 50% increase in the glomerular filtration rate in the second and the third trimesters. So renal blood flow also approximately, we can say, increase by 50%. Okay. Now, because of this, as a result of this increase, now the pregnant woman will have some symptoms like increase in frequency of micturition, increased frequency of micturition, and also nocturia. Okay. and also nocturia. Now, this is mainly because of the increase in the renal blood flow and the GFR. Now, what happens if the glomerular filtration rate falls? Okay. Now, what happens if the glomerular filtration rate, increases? This is hyperfiltration. This is in short told as hyperfiltration in pregnancy. Okay. Okay. And also note that because of the progesterone effect, there is a stasis phenomenon which occurs, which leads to dilatation of the ureters, which is hydroureter. Okay, dilatation of ureters leading to hydroureteronephrosis. So hydronephrosis is a phenomenon which is common because of the stasis in the ureter and also because of the compression of the ureter by the gravid uterus, and this is more marked on the right side. Hydronephrosis more marked on the right side, right greater than the left, and that is mainly because of dextrorotation of the uterus. Why it is more marked on the right side? Even this hydroureter, hydronephrosis, both are marked on the right side. That is because of dextrorotation of the uterus, which compresses the ureter against the pelvic brim. Okay, so that is another important point to note. Okay, now because of this hyperfiltration, the next point to note is that the serum levels of urea and creatinine will fall in pregnancy. So normal level of urea and creatinine will fall in pregnancy. Here the must point or the most important point that you should know is the normal range for creatinine will change in pregnancy. You cannot say 0.7 to 1.1. It is somewhere between 0.5 to 0.7. Now, any value any value of serum creatinine which is equal to or more than 0.9. So please remember, equal to or more than 0.9, we have to evaluate for renal disease or renal damage. Evaluate for renal disease. Now, another question that is usually asked is the effect of preeclampsia on renal blood flow and glomerular filtration rate. So the effect of preeclampsia is just the opposite of the normal physiological change that is occurring. Now, the renal blood flow decreases. So as a result of this, the glomerular filtration rate also will decrease. So what happens consequently as a result of this? The level of urea and creatinine increases. And preeclampsia is a very important cause for renal failure in pregnancy. Is that okay? So if they ask you what is the most common cause of renal failure in pregnancy, it is usually abruption. Okay. Another cause of renal failure in pregnancy is preeclampsia. So this is all you have to know about the renal changes. Now, we should talk about proteinuria and glycosuria. First, let's talk about proteinuria. Okay. First, let's talk about proteinuria. So proteinuria, and we also need to talk about glycosuria. See, both the excretion of protein and excretion of glucose in the urine is not something abnormal in pregnancy. It's a normal physiological change. We should know that beyond what cutoff we should take it as abnormal. So that is the point we should always remember. Okay. Two factors are operating here. What two factors are operating here? The first factor is the hyperfiltration factor. That is why hyperfiltration, because there is increase in glomerular filtration rate. So there is hyperfiltration. Number two factor is there is decreased tubular reabsorption occurring in pregnancy. Decreased tubular reabsorption. So because of these two reasons, it is not abnormal to see proteins and not abnormal to see some amount of glucose spilling in the urine. Is that okay? So we have understood this. See, in non-pregnant females, the level, the cutoff beyond which we call proteinuria is 150 milligrams. In the 24-hour collection, if it's more than 150 milligrams, then we say it's proteinuria. But in pregnancy, now this cutoff cannot be taken. This 150 milligram cutoff cannot be taken because of these two factors. Now this cutoff, this threshold of declaring proteinuria should be raised. So we have the threshold, we have the cutoff as 300 milligrams in a 24-hour sample. Now this is a very important question in the exam. 300 milligrams in a 24-hour sample. Now, this is the definition for significant proteinuria in pregnancy. So we need to understand what is significant proteinuria in pregnancy. Okay. Now this is significant proteinuria, or in other words, we can say it should be 1 plus proteinuria, or 1 plus is equal to how much? It's equal to 0.3 grams per liter. Okay, so it should be at least 1 plus. We are not taking trace. It is 1 plus proteinuria, or 0.3 grams, or it is 300 milligram per 20 in a 24-hour sample, or you can say urine protein creatinine ratio should be more than or equal to 0.3. Okay, all these I will talk again when we talk about diagnosis of preeclampsia. But please remember the definition for significant proteinuria in pregnancy. Is that okay? Similarly, glycosuria. So glycosuria also, it's not abnormal, but whenever a woman has glycosuria, we have to rule out gestational diabetes. Okay, it's normal, but then still we have to rule out gestational diabetes. So this is all about what? The renal system changes. So I want you to remember the cutoff for creatinine beyond which we take it is abnormal. And I also want you to know that hydronephrosis is common in pregnancy. It's more common in the right side when compared to the left side. I also want you to remember the definition for significant proteinuria in pregnancy, because it is one important point with which we diagnose what? Preeclampsia. Okay, now talking about the gastrointestinal changes, you know, there is stasis, there is delayed gastric emptying and all that. More particularly, we need to talk mainly about the liver and the gallbladder. Okay, now talking about the liver, I told you the kidney size increases by 1 centimeter, but remember the size of the liver will not change. So no change, I will draw a line like the size of the liver does not change, but there is increase in synthesis of proteins by the liver. All the liver proteins or synthesis of proteins increases. Okay, for example, say what all proteins, say thyroid binding globulin increases, cortisol binding globulin increases, ferritin binds to iron, so ferritin increases, ceruloplasmin increases. So like this, a synthesis of all the proteins, binding proteins will increase. Okay, so bilirubin, when we take liver function test, when we take bilirubin, there is no change in the levels of bilirubin. Okay, but alkaline phosphatase, placental production is also there. Therefore, in pregnancy, with reference to alkaline phosphatase, there is a 2 to 4-fold increase, which is taken as normal. When we take the enzymes AST and ALT, they usually slightly fall in pregnancy. There's a small fall. Usually we take the upper limit as 40, no? But here the upper limit comes to 30. So 40 international units per liter. We say 10 to 40 international units. Here it is like 10 to 30. Okay. Okay. So usually there's a small fall. So this is with reference to the liver function test, where bilirubin, total proteins, and alkaline phosphatase, and the enzymes AST and ALT. Now, when we talk about the gallbladder, we all know that because of the effect of progesterone, there is a relaxation of the gallbladder, and because of the effect of because of this relaxation, there is a decreased gallbladder contraction. This decreased gallbladder contraction combined with increased stasis. Not only there, combined with increased cholesterol saturation of bile, Now, as a result of this leads to increase in the gallstones, especially increase in the cholesterol gallstones. Increase in the cholesterol gallstones in the gallbladder. So it is not uncommon for pregnant women to develop gallstones in pregnancy. Is that okay? Fine. Now, the most important questions that come usually are from the requirement of iron and calcium, which we should know. So I've included it here. We will also talk about iron deficiency anemia later in our classes. But before we go on to that, we will finish off the general requirements of iron and calcium. So the traditional requirements mentioned are fetus needs 300 milligrams of iron for its making of blood. Okay, so you can remember 3 kg fetus needs 300 milligrams. And mother, for her RBC expansion, mother needs 500 milligrams. See, some amount of iron is conserved in all these 9 months of amenorrhea. Also, some amount of iron is lost during delivery. So, taking this plus minus into consideration, taking all the plus and minus into consideration, we can say the total amount of iron that is required per pregnancy is 1000 milligrams. So, mostly questions will come from these 3 values. Okay, fine. Now, pregnancy itself is a relatively iron deficiency state because the iron deficiency state, because the baby also needs, fetus also needs iron. So when it comes to calcium, the requirement is 1 to 1.5 grams per day. Okay, so that also has to be remembered. So finally, the endocrine changes. I'll take a couple of minutes to discuss the endocrine changes. We will start with the pituitary gland. Okay, now the pituitary gland itself increases in size. Okay, now when we take all the pituitary hormones, we will list all the pituitary hormones in order: growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, follicle stimulating hormone, luteinizing hormone, and prolactin. Now, these are all anterior pituitary hormones. Posterior pituitary hormones: oxytocin, arginine, and vasopressin. Is that okay? The growth hormone levels increase in pregnancy, and this is partly responsible for the weight gain in pregnancy. Thyroid stimulating hormone, there is no change. I'll give you a small clue. Everything with regard to the adrenal gland will increase in pregnancy. Fine. Pregnancy, you can take it as a state of stress. Stress hormones are increasing and adrenal hormones are also increasing. When we take FSH and LH, because of a negative feedback due to elevated estrogen and progesterone, FSH and LH level will fall. Prolactin levels are always high in pregnancy. Prolactin is also produced by the decidua also. The amniotic fluid prolactin levels are also high. That is because of the decidual production. Now, in spite of the elevated prolactin, there is no lactation in pregnancy because it is kept under the inhibitory influence of estrogen through dopamine. So after delivery, after the placenta comes out, the level of estrogen sharply falls, which leads to initiation of progesterone prolactin effect. Okay. Oxytocin levels are high and the levels increase much higher during labor, and the level of arginine and vasopressin. Now vasopressin level falls. Vasopressin level, there is no change. Okay, so make a note of this. TSH no change, arginine, vasopressin no change. Now when we take thyroid hormone, we have 2 more. So when we take thyroid, the requirement of iodine requirement in pregnancy increases. In the non-pregnant state, the requirement of iodine is something around 100 micrograms per day. 100 micrograms per day, but in pregnancy, it increases to 200 to 250 micrograms per day. So twice. So you can see that the requirement in pregnancy increases twice. Is that okay? As I had already told you, thyroid binding globulin secretion increases because of hepatic production. Now this leads to an increase in the total T3 and T4. But remember, free T3 and T4 do not change. As I have told already, thyroid stimulating hormone also does not change. So if you want to do thyroid profile in pregnancy, it's always better that you do TSH along with free T3 and T4 instead of doing total T3 and T4. So is that understood? As a result of elevated thyroid hormones, we know that the basal metabolic rate also increases by 25%. Is that okay? And I had already told you with reference to the adrenal hormones, almost all the adrenal hormones will increase. So if they ask you aldosterone, you say it increases. If they ask you cortisol, again you say it increases. ACTH already had told you it increases. So all the adrenal hormones, DHEA, DHEAS, all the hormones will increase. Is that okay? I think we'll go back and do the questions because we are running short of time. The first question, which of the following statement is false? We'll read one by one. Mother requires 500 milligrams of iron to form extra blood. Yes. Fetus requires 700 milligrams. No, it's only 300. Maternal cardiac output increases by 40%. Yes, 40 to 50%. BMR increases by 25%. Yes, so answer here is B. Effect of preeclampsia on GFR. Normally what? It decreases. Okay, so GFR is normally increasing in pregnancy, but preeclampsia will lead to a decrease. Which of the following statement is false regarding physiological change in pregnancy? Increased GFR? Yes. Increase in cardiac output? Yes. Increase in total proteins? Yes. What about residual volume? The residual volume decreases. We had already told that the residual volume will decrease. The total lung capacity will decrease. functional residual capacity will decrease. Now, all the three factors will decrease. You can go back and revise all the points that we have studied in respiratory system changes in pregnancy. Is that okay? So the answer here is increased residual volume is a false statement. With regard to option D, increased total proteins. Yes, total proteins are increasing, but because of hepatic synthesis. But when you see a word added after protein like concentration, what happens to the total protein concentration? It definitely falls. Is that okay? So I end this session today. I've taken a couple of minutes more. So I'll meet you all again on Monday with a very small topic of 15 minutes. So I think we have done almost all the points in physiological changes. What are left will be focused on the Monday's class. So thank you so much.
Yeah, moderator, am I audible? Just confirm, am I audible? Moderator, please confirm, am I audible? Yeah, thank you. So good evening, everybody. So today's class will be on, again, continuation of these new drugs. The whole week we have been seeing this. So let's finish this week as well with the new drugs. Just a second, I'll increase the volume. Yeah, I'll be more audible now. Yeah. So the first drug which we are going to see is called, it's a new topic that is called axon skipping therapies. That is called axon skipping therapies. So where it is useful mostly, this axon skipping therapy is useful for Duchenne muscular dystrophy. So how does Duchenne muscular dystrophy occur? It is mainly because of mutation of DMD gene. So what happens when the DMD gene mutation occurs? When DMD gene mutation occurs, the DMD RNA changes. How does it change? Because the dystrophin gene becomes non-functional. The dystrophin gene becomes non-functional. So what happens? Post the mutation, wherever in an exon there is a mutation, the reading frame of the RNA is altered down the mutation. So the entire dystrophin gene is non-functional here. And the reading frame below the level of the particular exon cannot be read. So the reading frame is altered, of the RNA is altered. So this dystrophin gene is made up of 79 exon transcript. It's the highest, longest gene in the body. This dystrophin gene is the longest gene in the body. It is made up of 79 exons. So there are various places where mutations can happen. So what is the use of this exon skipping therapies? When you skip the exons at the point where mutation happens, below that point, the reading frame again changes so that it adds to the functionality of the dystrophin gene. That is what is the significance behind this exon skipping therapy. So the particular point of exon where you have a mutation, which results in the reading frame change below down the mutation, you skip that exon, particular exon, and the drug goes and acts in the antisense oligomers. It goes and acts in the segment that is below the level of exons, and it converts that into a functional exon. So what happens? The gene becomes functional. Productivity of the gene is increased, restores functions and balance of the dystrophin protein. The protein is responsible for everything. So first drug here is eteplirsen. So everything ends here as sen because antisense oligomers. So everything will end up as sen. Goldie's sen, Casimirsen. So all will be sense here. So eteplirsen. For what exon this is acting? This is for exon 51. Remember this. This is for exon 51. So when you give this drug, it skips this exon 51 where there is a mutation. So what happens? The reading frame that is present down the exon changes. It is able to be read properly. It adds to the functionality of your dystrophin protein. So for DMD, restores functional balance of dystrophin proteins. But same drug when you give for healthy patients, there is no addition of functionality to the dystrophin protein. So there has to be a mutation and there has to be a exon that is damaged, and this has to skip it and then go to the next segment. Okay. Usual T half is about 3 to 4 hours. It gets eliminated within 24 hours, usually given IV. All this group of drugs are given IV. Similarly, golodirsen. This is for exon 53. Same mechanism and everything. It is also given IV. Elimination is to 24 hours. Casimersen. This is for exon 45. So there are 3 drugs in this class. Eteplirsen for exon 51. Golodirsen for exon 53. And casimersen for exon 45. All are given IV. Most common side effects noted: headache, joint pain, arthralgias, respiratory tract infections like oropharyngitis, bronchitis can be noted. Some patients also present with cough and abdominal pain. Rashes is also possible. Okay. So this is about your exon skipping therapies. The second group of drug is a latest approved drug that is used for vulvovaginal candidiasis. So it's an antifungal. It is called ibrexafungerp. Ibrexafungerp. Okay, so it is a oral antifungal. You just remember IB and fungal. So the drug that starts with IB and fungal, it's a new drug. Okay, ibrexafungerp. It's an antifungal. It belongs to the class of drugs that is called as enfumafungin. What is it? Enfumafungin derivative is a special class of drug. So what does this do? This is used for vulvovaginal candidiasis. See, this beta-1,3 glucan synthetase inhibitor. Okay, it's a glucan 1,3 synthetase inhibitor. That is means it decreases the levels of beta-1,3 glucan synthetase. When it happens, the beta-glucan formation is reduced. So beta-glucan is an essential component of fungal cell wall. Basically, it reduces a fungal cell wall synthesis. It's a synthesis inhibitor. So it reduces the levels of beta-glucan by inhibiting the enzyme beta-glucan synthetase. So where do we use this? It is only used in cases who are resistant to echinocandins. So echinocandins is also a group of drug which acts by the same mechanism, beta-1,3 glucan synthetase inhibitor. It is also. But then how, sir, it is different? You might ask me that question. There are 3 domains where in beta-glucan synthase where these drugs can act. That is, one is FKS1 domain, FKS2 domain, and Rho1 protein domain. This echinocandins binds to only FKS1 domain, whereas this enfumafungin derivatives binds to FKS2, FSK2, FKS2 domain, and Rho1. Both are same, FKS1, FSK1. Both you can use it that way. So it binds to different domain when compared to echinocandins. So why it is used for vulvovaginal candidiasis? It has greater vaginal tissue distribution. It has greater vaginal tissue distribution. It is given orally. 300 mg. Half-life is 20 hours. So you once daily dosing is enough. CYP3A4 metabolism. It has a different elimination, fecal elimination. The main point here is no adverse events till date noted. No adverse events. Even the clinical trials, there was no adverse events, even when the dose was given above the maximum tolerated dose. The maximum tolerated dose is around 600 mg daily. Even in that dose, there was no side effects noted. That is a plus point of this drug. So ibraxafungerp, where it is used for vulvovaginal candidiasis. It's a oral antifungal, enfumafungin derivative. How does it do? Act? It reduces the glucon synthetase inhibitor, thereby it inhibits the beta glucan formation. Fungal cell wall synthesis is stopped. So this is used in resistant cases to echinocandins. How different is it from echinocandins? Binding domains. Echinocandins bind to FKS1 domain. Enfumafungin derivatives bind to FKS domain 2 and Rho1 protein domain. It has greater distribution, 300 mg oral. T-half is around 20 hours. CYP3A4 metabolism, fecal elimination, no adverse events. Okay. Next, last drug. It's a very interesting drug. It is called as Odivixibat. Odivixibat. How, sir, to remember all these things? Why are you torturing us like this? Very easy. The last 4 letters. Very easy. The last 4 letters. IBAT. The last 4 letters. IBAT. Odivixibat. It is a selective IBAT inhibitor. It is a selective IBAT inhibitor. So what is IBAT? IBAT is nothing but intestinal bile acid transporter. Intestinal bile acid transporter. So what is the use of this intestinal bile acid transporter? It helps in reabsorption of bile from distal intestine, mostly your cecum. So whatever bile acid is produced in the body, it goes to the intestine and is excreted out. But this transporter helps in reabsorbing some of the bile acid to maintain the balance. When this drug is usually indicated for pruritus. Sir, bile acid, pruritus, yeah, when bile acid is increased in the body, it can cause pruritus. But in what condition? It is indicated for, it's indicated for progressive familial intrahepatic cholestasis. This is a genetic condition. Progressive familial intrahepatic cholestasis. One of the main presenting symptoms of this condition is first pruritus. Then you will get fibrosis, intrahepatic cholestasis, ultimately death. The only treatment for this is, till date, it is liver transplantation. The only treatment till date is liver transplantation. But now, this drug has come to treat the pruritus, which is very severe in these patients. So there are 3 types, type 1, type 2, and type 3. One thing you have to remember here is type 2. There are different genes that is going to get mutations because in each type. ATP-A-B1 gene in type 1, ABC2 gene in type 2, ABC11 gene in type 2, sorry, and ABCB4 gene in type 3. But what is the difference, sir? Why we want to know all these things? Yes. Type 2 will have lack of bile acid export pumps. There won't be any pumps at all to reabsorb bile acids. Okay. Or to secrete bile acids. So the bile acid pumps only is not, export pumps only is not there. So this particular drug will not be effective against that particular type. So it will be only effective against type 1 and type 3. So what happens when you give this Odivixibat? It's a inhibitor of IBAT. IBAT is for reabsorption of bile acid back to your body. This reduces the reabsorption of bile acids. Thereby, it reduces your pruritus. It is first FDA approved drug for pruritus due to progressive familial intrahepatic cholestasis. How it is given? Oral 6 mg once a day dosing. That's the maximum tolerated dose. Even a kid of 3 months old can be given this. It can be given from 3 months old to adults. Oral 6 mg once daily, maximum tolerated dose. This drug has no metabolism. It is not metabolized at all. 2 to 6 hours is your half-life. So what will be the adverse events? Since this is dealing with liver and everything, fat absorption, fat soluble vitamin absorption is reduced, A, D, and K. It can cause diarrhea. It can increase your liver enzymes, LFT. So Odivixibat, how to remember? IBAT, last 4 letters, selective IBAT inhibitor. It is used for pruritus due to progressive familial intrahepatic cholestasis. There are 3 types, type 1, type 2, and type 3. You should not use it for type 2 because it is not effective, because type 2 lacks bile acid export pumps. This IBAT usually usually helps in absorption of bile from the distal intestine, reabsorption. When you give an inhibitor, it reduces the reabsorption, thereby it reduces pruritus. Orally given 6 mg once daily, maximum tolerated dose. It can be used from 3 months old kid to adult age group. No metabolism, not metabolized at all. 2 to 6 hours is the half-life. Adverse event, very common adverse event noted is A, D, E, and K vitamins, reducing the fat soluble vitamins, diarrhea, and LFT. Okay. Now coming to one question of the day. Now we'll read. A 4-year-old kid had some severe pruritus bar jaundice. Okay. So this shows that liver is affected, bile acids may be increased. First, investigations revealed intrahepatic cholestasis and diagnosis of progressive familial intrahepatic cholestasis type 2 was confirmed. Patient was started with IBAT inhibitor once daily. Which of the following is a correct statement? It's a very difficult question if you don't know about this drug. Had you not listened to this class, this question can be expected in AIMS. So, which of the following is a correct statement? IBAT inhibitor is urodeoxycholic acid, UDCA. No. What is IBAT inhibitor? OD-Vixi-BAT. So, it should end in IBAT. So, this is a wrong statement. OD-Vixi-BAT is given as infusion. No, it's given as oral drug. OD-Vixi-BAT has severe toxic effects. Narrow therapeutic index. OD-Vixi-BAT is effective against type 2 PFIC. So what is this? How to answer this question? So we know this type 2 PFIC is not going to respond to OD-Vixi-BAT because they lack bile acid export pump. So this is also wrong. The last option left is OD-Vixi-BAT has severe toxic effects bar narrow therapeutic index. This might be a true answer. This has narrow therapeutic index. Severe toxic effects can be seen. Vitamins, diarrhea, LFT, very severe forms can be seen. So remember, when certain sort of question is like this, ask first rule out the other options. And remember this option for this particular drug, it can cause severe toxic effects bar narrow. It has narrow therapeutic index. Okay. So other things that can be used for pruritus in progressive familial intrahepatic cholestasis, you can use UDCA, which is a urodeoxycholic acid. It's a bile acid sequestrant. Okay. And bile acid sequestrants can also be special group of drugs called bile acid sequestrants. They can also be used. Okay. Yeah. So first drug we saw is exon skipping therapies 51, 53, and 45. Eteplirsen, Goldirsen, Casimersen, all sense, antisense oligomers, Duchenne muscular hypertrophy. So they increase the productivity of the Duchenne muscular gene. Most common adverse effect, arthralgias and headache. Next is Ibrexa fungerp, special class enfumafungin derivatives. Vulvovaginal candidiasis, oral drug for vulvovaginal for resistant cases to echinocandins. Different domain binding when compared to echinocandins. Then comes your OD-Vixi-BAT, IBATs, which we discussed now. It is used for pruritus due to progressive familial intrahepatic cholestasis. So narrow therapeutic index, you remember. Okay. So it can cause severe toxic effects. So that's it for the day. So that's it for the week also. So next week we'll come with special topics. New drugs are enough as of now. So we'll go for some high yield topics for INICET 2021. Yeah. Have a nice weekend. Revise my slides. The whole week slides, you please revise or see the videos again once again. Yeah. Thank you.
Hi friends, good evening from the technical team. Am I audible and visible? Yeah, okay friends, we shall start this session today. Hi friends. Good evening friends. Today we are meeting on a fine Friday evening. Today's my topic is going to be the radiology of women's imaging. And here is myself, Dr. Aditya, your radiology faculty. So let's get into the topic of discussion today, that is women's imaging. So what and all comprises of women's imaging in radiology is, we will be discussing about bilateral breast, uterus, bilateral fallopian tubes, ovary, cervix and vaginal canal. In that, what I have done today is, I have taken a very important potential MCQ that has high chances of getting repeated in the upcoming INICET exam, and we will be decoding the question, decoding all the 4 options, and which is the correct answer, how I came to the correct answer. Then clinical aspect of radiology will be discussed with you. Also with that, what we will be doing is, we will be integrating radiology along with all the other subjects that comes under the MBBS curriculum. Let's get to the question, friends. Okay. The question for today is, a female had miscarriage abortion for 3 times. What is the investigation being done? First, the question here is, what is the investigation being done is the question. They have given an image like this. From that, what we have to find is, they have given all the 4 modalities of radiology, the basic modalities. We have to find what is the image given. First of all, I will decode the question for you. The question is, a female had miscarriage. Sir, what is miscarriage? Miscarriage is another term for abortion. Okay. For 3 times, this has to be noted. Why, sir? 3 times means that patient has recurrence of abortion. That is called, in a radiological term, habit. It has become a habit for them. Habitual abortion or miscarriage. Okay, friends? This is one extra point. Good to know. Okay, they have given an image, and the 4 options they have given are hysterosalpingogram, hysterosalpingography, saline infusion hysterosalpingography, or sonosalpingography. They are just the other names I have added so that you won't, even if they give the another option, you won't make the mistake. That's why. Okay. And CT hysterosalpingography and MRI pelvis. First, here what you should know is hystero. Hystero means uterus. Salpingo means fallopian tube. Gram or graphy means study. So if they give gram or graphy, both are same. Okay, friends. Next, this is the first option. So uterus and fallopian tube study using what? Using X-ray. And the second option is saline infusion hysterosalpingography, study of uterus and fallopian tube with the help of saline infusion, or sono. Sono means what, friends? Sono means sound. So sound is ultrasound. So the next modality they have given is ultrasound. Third modality what they have given is CT hysterosalpingography, study of uterus and fallopian tube with the help of CT. Okay. And MRI pelvis. MRI pelvis means the entire pelvis. It includes uterus and fallopian tube in case of female. So we will be doing a MRI. What you have to find is the given image is what. First, I will tell you a shortcut. See, the ultrasound image won't be like the other 3. What are the other 3? X-ray, CT scan, and MRI. X-ray, CT, MRI will be like a 2-dimensional image. See, it will be like this only, friends. X-ray, CT, and MRI will have that difference in the resolution. This is difference in the details of the structures present. Okay. ultrasound images will be very different. It will be grainy in appearance. It will be like a sand, black, white, gray sand. It will be like an image like this. Okay, I will show you the image. So from this itself, what you can do, you can eliminate the option ultrasound. Okay. Now the question is whether it is a X-ray image, whether it is a CT scan image, whether it is a MRI image. So first I will tell you the difference. Always look at the bone part. Okay, the bone part. If the bone, see, this is the bone part, and the bone part's outer surface appears white. Okay, if the outer surface appears white, that means the image is trying to give us more detail about the bone. So when a modality gives more details about bone, it has to be X-ray or it has to be a CT scan. Why, sir? Why not MRI scan? Means in MRI, naturally, what we do is we will dull out the bone. So we are not concerned about bone here. We are concerned about all the soft tissues, tendons, ligaments, muscles, everything. Okay. So from this itself, we can remove MRI as option since bone is appearing white here. Bone is appearing white. So what is, whether it is X-ray or CT scan? Friends, compared to X-ray, CT scan will be very much high resolution and detail. This is like a what? This is like a very vague image. So with that, with all these things in mind, we are coming to the diagnosis of hysterosalpingogram or hysterosalpingography. This given image is an X-ray image. X-ray image of uterus and fallopian tube. Okay. Now we will be discussing each and every modality in detail. So at the end, when I show you the question, you itself can say the answer. Let's move ahead. Okay. First thing is hysterosalpingogram or hysterosalpingography. As I said, it is a study of uterus and fallopian tube. Graphy always means study. So I have given the definition of this. The definition is it is an X-ray procedure, as I told you, used to view the inside. This is very important for our next question. I will say why. Inside of the uterus and fallopian tube. Inside of the uterus and fallopian tube. It often used to see if the fallopian tubes are partly or fully blocked. Why, sir? If the fallopian tube is partly blocked or if it is fully blocked, there are high chances of the women not able to get conceived. Okay, so it is one of the reasons for infertility. This has to be in the back of your mind. It also can show if inside of the uterus is of normal size and shape. So what is the significance of this line is, see, there are a lot of anomalies of the uterus and fallopian tube. In the radiology, we used to say it as Mullerian duct anomalies. Okay. In order to find that, we do hysterosalpingography. Normally, the study is performed. Look at this image. This image also looks like the image I showed you in the question. Okay. Here, always look at the bone part. The bone, not the bone part, the bone edge part. Okay. The edge part is appearing white here. If it is appearing, see, look at here, it is appearing white. That means it is an X-ray of the uterus and fallopian tube in radiological term, hysterosalpingography. Next, we will be discussing a clinical aspect of it. Here, friends, this has been repeated. This has been repeated in the NEET 2018 question. Look at this image. This is a hysterosalpingography image. Everyone will be able to see. Inside, you see, you are able to see the structure, right? This structure is the inside of the uterus. What will be inside of the uterus? There will be endometrial cavity, right? The endometrial cavity here is filled with the contrast material. Hence, we are able to appreciate how the uterus is appearing. This appearance is the banana-shaped uterus. Okay, and banana-shaped uterus is typical of what? It is typical of unicornuate uterus on hysterosalpingography study. Okay, banana shape. Remember the banana. Okay, unicornuate uterus means uni means one, cornua means one opening. Okay, so it appears like this, right, friends? Normally, it should be like this. But how it is appearing here like this? Hence, it is unicornuate uterus or hysterosalpingo study. I think you are clear with this. Let's move on to the next modality. Okay. When to now I will discuss further when to do a hysterosalpingography study. When should I perform, sir? Okay. Hysterosalpingography study will be seen inserting a cervical cannula. A cannula will be inserted through the cervix. We will inject iodinated contrast and we will be doing a fluoroscopy study. What will happen? The contrast will outline the uterine cavity, bilateral fallopian tubes, and through the fallopian tubes, the contrast will be spilling into the peritoneum. Okay, this is how we will perform the study. Okay, sir. Next, I have given here a very important image. This has been also asked in NEET PG 2020. All has been collected questions. I am giving you all the details regarding those questions so that you won't make mistakes in this question. The image shown here is a spot image. Look at the bone part. The bone part is appearing white, right? And it is appearing far away than a CT scan. Hence, it is hysterosalpingography study showing bilateral. Look at the dilatation. See, it appears dilated, right? These are the fallopian tubes which are dilated. Okay, and they are appearing retort. So, what does retort mean? Sharp demarcation is present. And no peritoneal spill. It normally should spill through the fallopian tube into the peritoneum. Here it is not spilling. Hence, there is block present there. Hence, we are coming to a diagnosis of bilateral hydrosalpinx. Remember, friends, when you are given such an image, this all knowledge should come to you and you should crack the exam with the help of bilateral hydrosalpinx. For this question, the answer is bilateral hydrosalpinx, this image. Next, so in what situations and all we will be doing a hysterosalpingography studies? Mainly, as I told you, it is for infertility evaluation. We will be looking at the tubal patency. What is tubal? Fallopian tube. Fallopian tube patency or hydrosalpinx is whether present or not. Remember the word hydrosalpinx because later I will be telling you another important thing when we come to MRI of the pelvis. Mullerian duct anomalies, as I told you, unicornuate uterus, bicornuate uterus, and septate uterus. Also, hysterosalpingography is used for uterine adhesions like Asherman syndrome. So, what is Asherman syndrome? Postpartum, the patient will have uterine syncytiae, that is Asherman syndrome. Okay, friends, these are all the indications for hysterosalpingography. If I frame a question, what I will do? Hysterosalpingography is done in all the above conditions except. So since we have three options, I will put a fourth option, anything, and I can frame an easy question for you. So it is a potential MCQ for the upcoming exam. Next, this is an important question. What would be the best time to do a hysterosalpingography study in a reproductive age group female is? Remember the 10-day rule. Okay, it can be done in the first 10 days of the menstrual cycle. Okay, but in the first 5 days, what happens? The woman will be having her menses. She will be bleeding. During that time, injecting a contrast and doing the studies practically, it is not good for the patient. At plus, practically not. We won't recommend it. Hence, the first 5 days we won't be performing. We will be doing in the 6th, 7th, 8th, 9th, and the 10th day. So this is what I have given here, but it is impractical to do it during menses time, into which will introduce infection. Hence, the best time to do a hysterosalpingography is just after the bleeding stops on the 6th, 7th, 8th, 9th, and 10 days. This is also a potential MCQ. Okay. Let's move ahead. Next is CT hysterosalpingography. So same like that, hystero-uterus salpingo fallopian tube study using CT scan. Friends, for your level of MBBS entrance exam, that is a PG entrance exam, CT is very much high level for you. There is a book written on this. Just the option name, there is a book written. Hence, they won't get into more for questions regarding for you. But what we will do is, I will tell you the other names of city because it can be put in an option to confuse you. They can give CT hysterosalpingography. It is also called virtual. Remember the word virtual hysterosalpingography, also called multi-detector CT hysterosalpingography. All these terms are same. Virtual multi-detector CT as well as CT hysterosalpingography. Okay, the images will be, look at the bone part here. It is very much white, right? Bone is very much white. The outer cortex of the bone is very much white. Means X-ray or CT scan. If it is not that much white and the white has been decreased, means MRI study. I will show you next. But this is very much high for your level, hence they won't go much into this. But I have added images for you, sir. So how you are saying CT is far better than X-ray is? First of all, the resolution. We can know very much details about what is present inside the bone, whether any abnormalities in the bone. Okay, and we can also get a three-dimensional image of the uterus and fallopian tube like this. Even the endometrial cavity also we can get images. So these and all help in the diagnosis. Hence, it is far better than doing a X-ray. Next, the last option, MRI pelvis, and also ultrasound. Okay. Now we will be discussing ultrasound hysterosalpingography. So what is this? Remember here, you should know certain terms. I will make it easy for you. Hysterosalpingography, as I said, sometimes they can add the word sono. Sono, just the 4 letters will make a huge difference. Sono means ultrasound. In ultrasound of the hysterosalpingography, what we inject is saline. Hence, they can add the word saline hysterosalpingography. Also called saline histogram, also called sonosalpingography. All the terms means the same, friends. Okay. Here what we will do is, we will use a transvaginal. Through the vagina, we will be inserting the probe to confirm tubal patency by visualizing turbulence near the fimbrial end of the fallopian tube, which a mixture of air and saline is injected through a Foley's catheter placed within the uterus. Okay. So, sir, what and all we can inject is, we can inject saline or foam. Both we can inject. So look at the image. As I told you, always the image will be like this, friends. This is just a shortcut which you can use. So what is this? This is what, where the probe will be. Okay, and we are seeing the image. As I told you, ultrasound image will be very much grainy in appearance, and this is how the uterus and the fallopian tube will appear. Here you are nicely seeing the fallopian tubes. Okay. Now let's move ahead. This is how an image of ultrasound HSG will be. Next, MRI of the pelvis. As I told you before, for hydrosalpinx level, we can perform X-ray. In case of pyosalpinx, whether pus is there, best investigation for choice for hydrosalpinx as well as pyosalpinx is MRI, and it is also the modality of choice for adenomyosis. I will have a brief discussion with you at your level in the next future classes. But for this class, what you should remember is, if they frame a question like best investigation for hydrosalpinx, MRI pelvis, best investigation for pyosalpinx, MRI pelvis, best investigation for adenomyosis, MRI pelvis. Now, friends, main important thing, look at the bone part. The bone outer edges are not white, okay? They have been very much dulled, so that other things around the bone are, you are able to see better clarity, right? So that is what MRI is all about. MRI, we are not concerned about mainly the bone part. We are concerned about the soft tissue surrounding. So I have discussed with you X-ray, ultrasound, CT, MRI. Now let's get back to the question. Now this is the image which I have put for you. This image is pure and purely X-ray. Okay. Hence I have come to the answer hysterosalpingography. In the same thing, I will discuss with you just another MCQ. Same, belongs to the same group, that's why. A 23-year-old female with a history of 2 stillbirths, abortion, infertility. All the 3 means the same. If they put the same word, you should mark the same answer. Hence, I have added the word. That's all. Ultrasound suggestive of uterine anomaly. Which test is done to confirm diagnosis? Friends, this is a very important question. You should not make mistake here because it's a AIMS 2020 repeat as well as NEET PG 2021 repeat. Hence, these questions are short, should not be made mistake here. The 4 options are: one is ultrasound, transvaginal, we are putting the probe, hysterosalpingography, that is X-ray, MRI is given as option, ultrasound is given, and last but not the least, hysteroscopy with laparoscopy. First, I will tell you a very important word in the question. Which test is done to confirm the diagnosis? Whenever they say to confirm the diagnosis or a gold standard test, it means that test must be diagnosing the disease as well as either it should be therapeutic. Okay, like endoscopic retrograde cholangiopancreaticography. Okay, or it must help us get, it must be diagnostic and we should get a biopsy specimen. For example, ultrasound guided biopsy, those things and all are gold standard. Likewise, hysteroscopy plus laparoscopy. So, hysteroscopy wise, let's say this is the uterus. Inside the uterus, if there is any problem, we can find with the help of hysteroscopy, and we will be performing an exploratory means we will be exploring the outside. So laparoscopy will be doing. So we will be able to see the outside of the uterus if any anomaly is present or not. Just remember this. This is very important. If the woman has uterine anomaly, and in that specifically, if she is having a bicornuate uterus or a septate uterus, it's a topic in itself. We'll be discussing ahead later. But right now, remember, hysteroscopy plus laparoscopy, since it helps us find both the inside as well as the outside, we are performing this. It's a little bit controversial question, but this is the sure answer for this question. Regarding the other options, ultrasound, X-ray and MRI, I will decode the options for you. Okay. See friends, we can do a transvaginal ultrasound, but it is not the best or it will confirm the diagnosis. It is not the best or it will not confirm. We can do it as a screening purpose. Hysterosalpingography X-ray done to make the uterine cavity and fallopian tube look white for better visualization. It is also a basic level test. It will not give us a confirmation or it's not the best modality. In that, even they can give the option of saline hysterosalpingography. Okay, saline will be same like water, right? So it won't look white on X-ray or CT scan. What we will be doing, we will be cannulating the cervix, we will be pushing the saline inside the uterine cavity. In ultrasound image, fluid will be appearing black, right, into the endometrial cavity. Through the endometrial cavity, it will enter the fallopian tube and it will be spilling into the peritoneum. So, in this line, what I have said is, when we do a hysterosalpingography X-ray, there the uterine cavity and fallopian tube will be appearing white X-ray. Okay, little bit white, grayish it will be. In case of ultrasound, fluid is always black. Just remember this, fluid is always black in ultrasound. For uterine anomaly, we need to look at endometrial cavity and the outer surface. This is from the standard book, okay? This is how we will proceed ahead. And as I told you, we must differentiate between septate uterus and bicornuate uterus. In septate uterus, the thing will be out. Remember, friends, outer surface of the uterus will be normal, but inside of the uterus you will be having a septa like this. Okay, this is what septate uterus is. Fusion has occurred. Fusion has occurred, but presence of septa between the two and outer surface will appear normal. Endometrial cavity will be separate. See, this is separate. This is separate. In case of bicornuate uterus, remember how it will be is the uterus itself will be like this, and it will be having a separate endometrial cavity. So two carnivora separated, also outer surface is separated. In order to look at the outer surface as well as the inner surface only, what we are doing hysteroscopy with laparoscopy, friends. That's why MRI also can be done. It was given in the option, but that is far better. Hysteroscopy with laparoscopy, when this both is combined, no, they are gold standard for finding all the uterine anomalies. Hence, for the question which I discussed with you earlier, this question, hysteroscopy with laparoscopy is the best answer. Okay, so today we have consolidated X-ray, CT scan, ultrasound, MRI of the uterus and fallopian tubes. These two questions can be a potential MCQ for the upcoming INICET exam. So give it a go, revise it, and thank you, friends. With this, we are coming to the end of the discussion today. Have a nice day ahead.
Am I audible? Can you just confirm if I'm audible, please? Okay. Hello everyone, I'm Dr. Sneha, and today we'll be discussing on one of the most important drugs in obstetrics. There are very few drugs that are very specific in obs and gynae, and Maxtel is one of it. And there's a reason that I picked this drug in particular, because I feel that this will definitely be one of the expected questions in the upcoming INICET. And as far as obstetrics is concerned, this is one of the drugs that's revolutionized the field of hypertension in pregnancy. So let's jump into the MCQ. Here we have a 23-year-old primary gravida at 38 weeks who has come to labor room as she complains of headache and blurring of vision for the past 4 hours. On examination, the pulse rate is 90, blood pressure 150/100, and there's bilateral pedal edema. Urine albumin is 2+. While examining her, she suddenly throws gender tonic-clonic type of seizure. So what is the drug of choice to manage this condition? Your options are phenytoin, phenobarbital, diazepam, and magnesium sulfate. Now for today, the answer is pretty much forward because the topic for the day is magnesium sulfate. But I would like to tell you in detail why that is the option. Okay, so let's look at some buzzwords in the MCQ that will help us to come to the diagnosis. The patients come with headache and blurring of vision with high BP and positive urine albumin. So high BP is gestational hypertension, along with proteinuria will become preeclampsia, and there is imminent signs and symptoms such as headache and blurring of vision. So the patient has severe preeclampsia. On top of that, she throws a seizure. So any seizure in pregnancy, if other causes, unless other causes are found out, you have to take it as eclampsia till you rule out other causes, okay? And for eclampsia, always the drug of choice and the first drug to administer will be magnesium sulfate, because the pathophysiology with which seizures occurs in eclampsia is different from the other types of seizure that you see normally in medicine, and that's why the usual anti-epileptics that are used in other medical conditions are not of much help in this condition. Okay, so let's look at a vial of magnesium sulfate. If you notice, magnesium sulfate comes in vials and it looks like clear water, and this is the most important part that I would like to highlight. Each ampule contains 1 gram of magnesium sulfate that is diluted in 2 ml of fluid. Okay, so that means that the concentration is 50%. Now, this is the most important thing in obstetrics when it comes to magnesium sulfate. You need to look at the concentration, and most of the ampules that are provided in our labor rooms will be in this concentration. It can be given either as IM or IV route. There are certain uses in magnesium sulfate. It is no longer used just for hypertensive disorders. The first, as we already discussed in the MCQ, is for treatment if the patient throws a fit, that is eclampsia. And even if the patient has severe preeclampsia, you can give it as prophylaxis, because a patient with severe preeclampsia has a very high chance that she might throw a eclampsia or a fit later. So somebody with severe preeclampsia, you can start Maxulf as a prophylaxis to prevent eclampsia. Okay. If the patient already presents with eclampsia, then this will be the drug of choice. Second, and a relatively newer use, is fetal neuroprotection. This means if for some reason you are planning to deliver the baby at a preterm gestation of less than 32 weeks. Now we know that a preterm baby has a lot of complications, including GI, brain, lungs. A lot of the organs are not developed properly at a preterm stage. So by giving Maxulf, they have proved that it can decrease future neurodevelopmental problems to some level in preterm babies. So if the baby, because of spontaneous onset preterm labor, or you are inducing labor at less than 32 weeks, you can consider giving magnesium sulfate for the purpose of fetal neuroprotection. Okay. The third use is tocolytic, but there are now better, more effective tocolytics present. So magnesium sulfate is not the first line tocolytic that is used nowadays, but for theoretical purpose, please remember that it causes uterine relaxation to some extent. So it is also, theoretically, it can also be used as a tocolytic. Okay. So now let's look at briefly at the pathophysiology of how seizure occurs in eclampsia. Okay, the main pathogenesis is vasoconstriction of the brain blood vessels. We all know that calcium plays a very important role in contraction of muscle, right? Calcium binds to the actin-myosin complex, and these lead to smooth muscle contraction of the muscles that are present on the walls of the blood vessels in the brain, which causes cerebrovascular vasoconstriction and edema, and this is what causes the seizure. So what does magnesium sulfate do? The action of magnesium sulfate is to antagonize this calcium ion, which is the main culprit for causing this vasoconstriction. Okay. Let's briefly look at the mechanism of action of magnesium sulfate. We know that the main point is that it has to decrease the calcium levels. There are 4 ways in which magnesium sulfate can do this. Okay. Now, just this is a presynaptic neuron, and this is a postsynaptic neuron, and the space between this is the synaptic space. Okay. And these green molecules are glutamate molecules. It's one of the neurotransmitters. Calcium ions are present in plenty in the synaptic space. This red color receptor is a type of receptor called as NMDA receptor, and this brown structure here is the mitochondria. Okay, so now let's start. Usually what happens is that glutamate is released into the synaptic space from the presynaptic neuron, and the calcium, this opens the NMDA and it attaches to the NMDA channel and opens the NMDA channel so that calcium in the synaptic space enters the postsynaptic neuron and it binds to the receptors that are present, which causes vasoconstrictions. Okay, now let's see where all magnesium sulfate can act. First, it can block the release of glutamate. Second, it can block the entry of calcium into the receptors. Third, it can block the receptors as well. And fourth, it increases the calcium uptake by the mitochondria so that the calcium pool that is available in the cell as such decreases, and it will not lead to vasoconstriction. So these are the four main mechanisms by which magnesium sulfate decreases the calcium pool in the postsynaptic neuron. So the net action, if you remember, please remember this, decreases the calcium pool, so which leads to vasodilation, and there is decrease in cerebral edema, hence decrease in seizure activity. Now there are two regimens, important regimens, by which I mean the ways in which you can give magnesium sulfate to indicated patients, Pritchard's and Zuspan. Pritchard is an IM regimen and Zuspan is an IV regimen. Okay, both of these has a loading dose to quickly elevate the level of magnesium sulfate into therapeutic range in the body of the woman because it's an emergency condition. And then you give a maintenance dose to maintain that therapeutic level. In Pritchard's, you give a 4 gram of 20%. Please note this is 20%. We saw in the first slide that the available ampule is 50%, right? So you have to reconstitute and make it into 20%. Give it as IV first, and then load 5 grams of the 50% and give a 50% magnesium sulfate and give as IM in each of the buttocks. This is loading. After 30 minutes, you give 5 grams in each of the buttocks, 4th hourly. Okay. So this is Pritchard. Now the disadvantage with Pritchard is that IM injections can be quite painful to the patient, and it is very difficult to keep loading, breaking the vials and keep loading 5 grams of magnesium sulfate every 4 hours. So that's when Zuspan regimen came. Zuspan is a fully IV regimen. The loading dose is same, 4 grams. You dilute it in NS solution and give it IV over 20 to 30 minutes. And after 30 minutes, you set the infusion pump at the rate of 1 gram per hour. In both the regimens, you need to give the magnesium sulfate for 24 hours from the time of eclampsia or time of delivery, whichever is later, because even if the eclampsia is controlled at that moment, there is a chance of recurrence later. So you need to give it for 24 hours afterwards. What about for fetal neuroprotection purpose? You can give the same regimen if IM Pritchard, if IV Zuspan. These are some of the other regimens that are available, and you can freeze the screen and go through them. Please note that some of the regimens do not have maintenance doses. Now, there are certain things that you need to monitor when you put the patient on magnesium sulfate, okay? Because magnesium sulfate toxicity can occur if not monitored. The first is patellar reflex. Second is to see if she maintains a respiratory rate of more than 14 per minute. And third is urinary output. There should be at least 100 ml in 4 hours. This is because in a normal person, in a normal body, if you check the magnesium level, it will be around 1.3 to 2.1 milliequivalents per liter. When you want to give magnesium sulfate for the purpose of preventing or treating eclampsia, you are aiming at a therapeutic level at a much higher level of 4 to 7 milliequivalents per liter. Note this. Please look at the unit properly because your options might come in different units. Now, this can be one of the MCQ questions, okay? If you convert it into milligram per deciliter, your value will become 4.8 into 8.4. An easy way to remember this is to multiply this value into 1.2 and you can convert it into milligram per deciliter, okay? Now, when the level crosses more than 10, what we're aiming is 4 to 7. If it becomes more than 10, patellar reflex is lost, okay? When it crosses more than 12, next respiratory paralysis occurs. What about urine output? Magnesium sulfate is a drug that is excreted through the kidneys. So if your kidneys are not working, magnesium sulfate can get backlogged in your blood vessels and it can cause toxicities. So before you start magnesium sulfate, it is important to check renal function. So at least a simple serum creatinine will do to see if she has any major renal problem, okay? What if the patient develops these magnesium sulfate toxicity symptoms? What is the antidote? We saw that magnesium sulfate antagonizes calcium ion that is responsible for causing the eclampsia. So the same principle is used as an antidote. Now, calcium can be given to magnesium sulfate to antagonize it. So the treatment here is to give calcium gluconate 1 gram IV and to stop the ongoing magnesium sulfate. Okay. There are certain very few contraindications where magnesium sulfate cannot be given. First is an underlying neurological conditions like myasthenia gravis, and the second, as we already discussed, is impaired renal function, because the magnesium sulfate is excreted through the kidneys, and in impaired renal function, it will cause backlogging in the blood vessels. Certain side effects, because it causes vasodilation, it can cause feeling of flushing, it can be quite painful to the patient and even cause sweating. For the baby, if you give magnesium sulfate for more to 5 to 7 days, it can cause hypocalcemia and bone abnormalities in the fetus. Previously, when it used to be given as tocolytic, that is when magnesium sulfate was given for such a long time. Now for eclampsia and preeclampsia, the maximum duration which we give is 24 hours. So this complication is quite rare now because we do not give magnesium sulfate for such a long period nowadays. Okay. Now, the last question, this was one of the AIMS question, okay? How do you make a 20% magnesium sulfate that is given as a loading dose in Pritchard's? If you remember, in Pritchard's, the loading dose is 4 grams of 20% magnesium sulfate, not 50%, but the available ampule that you have in your labor room is 50%. So let's calculate, okay? Now, you take 1 ampule of magnesium sulfate that contains 1 gram of magnesium sulfate in 2 ml of liquid. So the loading dose is 4 grams. So that means you take 4 ampules. So that is 4 grams. And totally, if you load this in the syringe, it will come to 8 ml. Okay. So now let's load our syringe up to 8 ml. Very roughly, this will be around 8 ml. So now you have loaded the syringe with 8 ml of magnesium sulfate, which actually contains 4 grams. Now let's do a very simple maths. Okay, there is 4 grams of magnesium sulfate in 8 ml of the solution. That is why it makes it 50% solution. Now, how much should you dilute this 4 grams? How much of solution should you dilute it to make it into a 20% solution? So now if you do this algebra, it will come to 20, okay? So that means you should dilute this 4 gram in 20 ml of solution to make it into 20%. There is already 8 ml present in your vial. You should fill it up to 20 ml. Your mark is till this. You need to fill it till 20 ml totally to make it into 20%. So you add an extra of 12 ml of normal saline. Add an addition of 12 ml of extra saline to take it up to 20 ml so that it becomes 20% solution. Okay, so this is one of the MCQ that was asked previously. How much of extra fluid you should add to make it a 20% solution? Okay, so this is how you do the calculation. I hope that was clear. So that's the end of today's class. I hope that was useful, and thank you so much for patient listening.
Very good evening to all. Am I audible? Okay. So in today's topic of pediatrics, we have acute rheumatic fever. Acute rheumatic fever is a very important topic from common entrance test point of view. Here in acute rheumatic fever, the newer things which are being asked frequently is regarding the diagnostic criteria, that is the modified Jones criteria. So we will need to understand in detail about the modified Jones criteria. So we begin with a question on modified Jones criteria and we try to answer that. And we also try to understand what are all the MCQs which you can expect from this regard. So not a minor criteria for diagnosis of acute rheumatic fever. So the options are fever of more than 38 degrees Celsius, first degree heart block, ESR of more than 60, and polyarthralgia. So which of them do you think the answer is? Like most of you would get it right, it is the polyarthralgia which is the answer for this question. So this is a recent change which is done in patients with acute rheumatic rheumatic fever whenever you are classifying them as ARF. So before we go into the details of the major criteria, the minor criteria, as well as the essential criteria, we need to know what is acute rheumatic fever. So you all know that group A beta hemolytic streptococcus is known for causing infective complications. So if there are any non-suppurative and immunological complication which can happen after group A beta hemolytic streptococcus infection, it has to be one, acute rheumatic fever. Other, it could be post-streptococcal glomerulonephritis. So acute rheumatic fever is one of the non-suppurative immunological complication of group A beta hemolytic streptococcus. Now, this immunological complication is not going to be affecting only heart. It affects the joints, skin, subcutaneous tissue, brain, as well as heart. So involvement of these 5 organs will result in the characteristic major criteria which you guys remember as per the guidelines. So you have to know that involvement of the skin, involvement of the joint, involvement of the subcutaneous tissue, as well as involvement of the brain can all be reversible except cardiac involvement. So except heart, all other effects are reversible. That means they require only symptomatic relief during the time of clinical manifestation. Except heart, all of them are reversible. That means heart involvement can be reversible partly or can be persistent. So if the patients have heart involvement which persists beyond the acute phase, then we call it as rheumatic heart disease. Rheumatic heart disease. So cardiac complications are significant in the absence of secondary prophylaxis and they culminate into chronic and life-threatening valvular heart disease. So basically, you need to know that acute rheumatic fever, whenever involves heart, can result in lifelong sequelae. And whenever you have a patient with underlying cardiac involvement or any patient with acute rheumatic fever which satisfies the modified Jones criteria, they have to be put on secondary prophylaxis in order to prevent recurrences. Secondary prophylaxis in patients with acute rheumatic fever is going to reduce the recurrence rate by about 50%. So this is in brief an overview regarding acute rheumatic fever. Now coming back to the question, what is the Jones criteria? So if you look into the modification of the Jones criteria in 2015, it has major criteria which includes carditis, polyarthritis, edema marginotum, subcutaneous nodule, and chorea. Minor criteria include clinical features of arthralgia and fever and lab features like elevated ESR, CRP, and prolonged PR interval. Now then supporting evidence required positive throat culture, rapid streptococcal antigen test, and elevated ASO titer. So this was the criteria which was used up till 2015. But in the 2015 and beyond, there was some modification for this Jones criteria, which we call it as revised Jones criteria. Now, what is this revised Jones criteria? Now, this revised Jones criteria requires that all patients with evidence of preceding group A streptococcal infection are to be diagnosed with acute rheumatic fever only when they satisfy major criteria and minor criteria, which can be in the form of 2 major criteria or 1 major plus 2 minor criteria. But the caveat here is it has further classification of the population into low risk population and moderate plus high risk population. So this classification of the population into low risk as well as high risk or moderate risk population is very essential, because there is subtle differences in the major criteria when it comes to when it comes to low risk population versus moderate or high risk population. So when it comes to carditis, whether it is clinical or subclinical, both carditis are taken as a major criteria. Previously, in the previous Jones criteria, which was before 2015, there is no incorporation of subclinical carditis. So basically, what is subclinical carditis? Subclinical carditis means cardiac involvement in patients with acute rheumatic fever in the absence of symptoms or clinical signs of carditis. So whether it is clinical or subclinical carditis, that is taken as a major criteria. When it comes to low risk population, the arthritis, specifically polyarthritis, is the only major criteria that is involved. But when you see the major criteria pertaining to arthritis in low risk, in moderate and high risk population, even monoarthritis or polyarthritis in addition to polyarthralgia, if either of them are present, then it satisfies major Jones criteria. So this was the thing which was asked in the previous question. So in the previous question, if we go back and see, the previous question was asking you about what is the major criteria, which of them is not a minor criteria. The fever, first degree heart block, ESR more than 60, all are minor criteria. Polyarthralgia is a minor criteria, but in low risk population. But when it comes to high risk population, it becomes major criteria. So in patients with high risk of acute rheumatic fever, you have this as a major criteria. So that's why polyarthralgia is the answer for this question. Now coming back to the table, if you see, polyarthralgia which is there is actually a minor criteria if you're talking in terms of low risk population. But if you're talking about polyarthralgia in high risk population, polyarthralgia is a major criteria. There's no significant change in chorea, erythema marginatum and subcutaneous nodule in low risk versus high risk population. The other minor criteria which are there in low risk population is fever, ESR and prolonged PR interval. Now the fever and ESR and prolonged PR interval are also seen in high risk population as well, but the cutoff for the fever, ESR and the CRP is slightly different. The cutoff for fever is more than or equal to 38.5 degrees Celsius in low risk population to be considered as a minor criteria, and the ESR cutoff is 60 or more, while CRP is more than 3. When it comes to moderate and high risk population, the fever cutoff is slightly lower, more than 38 degrees Celsius. ESR is more than 30 and CRP remains same. So these are the changes between the older guidelines and the recent guidelines. And the recent guidelines, the major changes include involvement of subclinical carditis as a major criteria and involvement of polyarthralgia as a major criteria for arthritis in moderate and high risk population. The minor criteria is also showing some changes in the form of a variable cutoff for fever and ESR. A fever of more than or equal to 38.5 degrees Celsius is a minor criteria for low risk population. So is ESR of more than or equal to 60. When it comes to moderate and high risk population, the cutoff is more than 38 degrees Celsius for fever and ESR for more than or equal to 30 millimeter per hour. So how do you interpret this modified Jones criteria? You need to have supporting evidence of recent group A streptococcal infection. How do you say that? Say so by demonstrating rising ASO titers, that is anti-streptolysin O titer, and rising anti-DNSB antibodies. Positive throat culture for group A streptococcus or a positive rapid antigen test is also going to be a supportive evidence. In the background of supporting evidence, if you have two major criteria satisfied or one major plus two minor criteria satisfied, then you call it as a first episode of acute rheumatic fever. Now, whenever you have recurrence of acute rheumatic fever, then you will have to consider two major criteria or one major plus two minor or three minor criteria in the background of recent evidence of group A streptococcal infection to be considered as diagnostic of a recurrent rheumatic fever. The next question comes is, how am I going to differentiate low risk population versus high risk population? So this gets us to the next question. As per the latest update on diagnosis of acute rheumatic fever, the low risk population is defined as which of the following? Option A states that those patients with acute rheumatic fever incidence of less than or equal to 2 per lakh school age children. All age acute rheumatic heart disease prevalence of less than or equal to 3 per thousand population per year. Those with acute rheumatic fever incidence of less than or equal to 1 per lakh school age children, or those with acute rheumatic fever incidence of less than or equal to 1 per 10,000 school age children. So this question is basically trying to understand whether you know the definition of low risk population or the moderate and high risk population. Whenever you want to define any population and the risk associated with it, we are talking in terms of prevalence as well as incidence. From this question, we come to an answer that the low risk population is defined as an acute rheumatic fever with an incidence of less than or equal to 2 per lakh school aged children. So answer for this question is A, but this answer is partially correct because the low risk population should be defined both in terms of incidence as well as prevalence. So this brings us to the next slide. That is low risk population versus high risk population. Low risk population is indicated by the fact that if the incidence of acute rheumatic fever is less than 2 per lakh school age children per year, or the rheumatic heart disease prevalence is less than 1 per thousand, then we call it as low risk group. If the cutoffs are more than the respective cutoffs of our incidence and prevalence, that is, if the incidence in children is more than 2 per lakh and the prevalence is more than 1 per thousand population, then we call it as moderate and high risk groups. So there is no differentiation between moderate risk group versus high risk group. Both are clubbed under same thing. So basically, the low risk population and moderate and high risk populations are differentiated in terms of modified Jones criteria as well. Now, how they are differentiated? The differentiation is pertaining to the initial attacks of acute rheumatic fever. So low risk population and moderate and high risk population will have to satisfy the same criteria. 2 major criteria or 1 major plus 2 minor criteria in the background of preceding evidence of group A streptococcal infection which has occurred recently. When it comes to recurrence of acute rheumatic fever diagnosis, the same criteria will hold good for low risk population, but for moderate and high risk population, even in the absence of a many major criteria, if 3 minor criteria are present in a patient with prior acute rheumatic fever, then that also will be considered as diagnostic of recurrence of acute rheumatic fever. Are you guys able to note this? These 3 minor manifestations can itself be diagnostic of acute rheumatic fever, while presence of only 3 minor criteria in low risk population is not diagnostic of acute rheumatic fever. Now, if you look into the major criteria, only polyarthritis is one of the major criteria for the purpose of diagnosis of acute rheumatic fever in low risk group. But in moderate and high risk population, you have polyarthritis, monoarthritis, as well as polyarthralgia as a major criteria. When it comes to minor criteria, polyarthralgia becomes a minor criteria for low risk population, while monoarthralgia becomes a minor criteria for low risk population. The cutoffs of fever is 38.5 degrees Celsius or more for low risk population, whereas for a high risk and moderate risk population, it is more than 38 degrees Celsius. The cutoffs for ESR is again 60 for low risk and 30 for high risk population. And this is in brief regarding the low risk versus high risk population. Then we go for the penultimate side, which summarizes the changes in revised Jones criteria. So to say this, the major changes includes: 1, the carditis definition. So carditis includes both subclinical and clinical carditis. That means I can make the diagnosis of carditis based on auscultatory findings of a murmur or a acute rheumatic murmur or a pericardial rub, or I can perform an echocardiography, and even in the absence of clinical murmurs or sounds, I can make the diagnosis of subclinical carditis if the echo shows acute rheumatic fever. So subclinical carditis is basically no murmur but with echocardiographic evidence of valvulitis. Now, what are the echocardiographic evidence of valvulitis? So Nelson textbooks of pediatrics is going to tell you about the echocardiographic findings in acute rheumatic fever. So pathological MR and pathological AR, there are 4 criteria for each of them in order to diagnose rheumatic valvulitis on echocardiography, which satisfied the definition of subclinical carditis. So two things are common for both. So if you have a mitral regurgitation which is seen in at least 2 echocardiographic views, or aortic regurgitation in 2 echocardiographic views, then one of the criteria is satisfied. If the peak velocity is more than 3 meters per second, then the second criteria is satisfied. Now the regurgitant jet, if the length is more than 2 centimeters in at least one view for MR and more than 1 centimeter in at least one view for AR, then the respective pathological MR and pathological AR criteria is understood. Since mitral regurgitation is associated with pansystolic murmur, whatever regurgitation is going to happen will happen during the entire systole. So if you perform a echo Doppler and if you are able to get a pansystolic jet, then a pathological MR is further confirmed. For pathological AR, since aortic regurgitation is associated with diastolic murmur and not systolic murmur, you are expecting a pan-diastolic jet in at least one envelope. So this is in brief regarding the echocardiographic findings in rheumatic valvulitis. So the changes includes changes in the definition of arthritis. Changes includes the definition of carditis and involvement of subclinical carditis. The changes also include the cutoffs for fever, ESR, as well as classification of monoarthralgia and polyarthralgia into various categories depending upon whether it is a low risk or a high risk population. So the next important question which is required to be known from exam point of view is where this Jones criteria is not applicable. So we have to understand that there are few certain conditions where you don't need Jones criteria for making the diagnosis of rheumatic fever. So what are those criteria? So here the question is, which isn't a condition where Jones criteria is applicable? That means 3 of these conditions are exclusions for Jones criteria and one of them is an indication for Jones criteria. So what do you think? So for first attack of acute rheumatic fever, never ever skip Jones criteria. So Jones criteria is the prerequisite for diagnosing the acute attack of rheumatic fever for the first time. However, the exclusions where the Jones criteria are not applicable include the rheumatic chorea, the chronic carditis, and recurrent carditis. These 3 things will not require Jones criteria to be satisfied to be called as acute rheumatic fever. Only the first attack of acute rheumatic fever is going to be diagnosed on the basis of Jones criteria. Rheumatic chorea, chronic carditis, and recurrent carditis does not require satisfying of Jones criteria in order to make the patient coming into acute rheumatic fever spectrum, and management will go on. So this is in brief regarding the acute rheumatic fever. We have learned today the modified Jones criteria, the moderate versus low risk population, the changes in the revised Jones criteria involving subclinical carditis. We have also tried to understand what is the criteria for pathological MR and pathological aortic regurgitation, and also we know now the exceptions of Jones criteria. I think at this point of time, I'll make way for the next faculty in line to continue the class. Thank you all.
Good evening, all of you. Today we are going to learn about the oxidation of fatty acids. Now, in almost 90% of the tissues, oxidation of fatty acids is basically for the energy requirements. However, there are few tissues which cannot use them. We will see them in a short period of time. I will start off today by telling about the different types of oxidation, the organelles in which these happen, and which type of fatty acid gets oxidized. The first and the most common one is the beta oxidation in mitochondria. It is for long chain, medium chain, and short chain fatty acids. Then we have the beta oxidation which takes place in the peroxisomes. It is for the very long chain fatty acids. Omega oxidation which takes place in the endoplasmic reticulum works only when the mitochondria does not oxidize medium chain fatty acids. And then we have the alpha oxidation which takes place in the peroxisome and for the branch chain fatty acids. Now, let us look into the beta oxidation. Now, what is beta oxidation? Beta oxidation is the oxidation of fatty acids on the beta carbon, between the bond between the alpha and the beta carbon, that is oxidized, and we remove the individual groups as 2 carbon compounds, the acetyl CoA. Acetyl CoA, right? Now, most tissue can oxidize the fatty acids, but tissues which cannot oxidize the fatty acids are brain, erythrocyte, and adrenal medulla. These 3 cannot oxidize fatty acid for the energy requirements. Coming to what are the 3 stages of beta oxidation? The beta oxidation takes place in 3 stages. First is the activation of fatty acids, which occur in the cytosol. Then the transport of the fatty acid into the mitochondria, where it will be oxidized. And finally, the beta oxidation proper in the mitochondrial matrix. Let's look at each of the stage. So the first step is the activation of fatty acid with the help of coenzyme A, and we require an enzyme here, thiokinase or acyl-CoA synthetase. Acyl-CoA synthetase, and 2 high energy bonds. 2 high energy bonds are broken here. 2 high energy bonds are here, and magnesium is also required. Thus, we have the activated acyl-CoA. Now, what happens to this acyl-CoA? Now, the inner mitochondrial membrane is impermeable to the medium chain and long chain fatty acids. It is permeable to the short chain fatty acids. So, we need a mechanism to transport this activated fatty acid into the mitochondrial matrix. For this, we have something called as the carnitine shuttle. Now, how it works is we have firstly a protein which is the carnitine, right? We transfer the acyl group from the activated acyl-CoA to the carnitine to form acyl-carnitine, and for this we have the enzyme CPT1, that is carnitine palmitoyl transferase 1, or it is also known as CAT1. It is carnitine acyl transferase 1, right? Now this acyl-carnitine travels all the way to the inner mitochondrial membrane, where we have the second enzyme CPT2 or carnitine palmitoyl transferase 2, which converts back into the acyl-CoA, thus entering into the mitochondria. Now, few things about carnitine, since we are talking about carnitine. The other name for carnitine is beta hydroxy gamma trimethyl aminobutyrate, right? We synthesize it from lysine. We synthesize it from lysine in the liver, and it is stored in the muscles. It is synthesized in the liver and stored in the muscle, and we require vitamin C for this, or ascorbic acid for this, right? Now, important thing here is when we are in a well-fed state, we have increased insulin to glucagon ratio. Thus, fatty acid synthesis starts, and acyl-CoA carboxylase, which is the rate-limiting step on the fatty acid synthesis, produces malonyl-CoA, and this malonyl-CoA inhibits this particular reaction, right? So that brings me to the first question for the evening. In a well-fed state, the activity of CPT1, that is carnitine palmitoyl transferase 1, in the outer mitochondrial membrane is inhibited by, the answer here is, you're absolutely right, it is malonyl-CoA. It is malonyl-CoA. Now, let's go into the beta oxidation proper. Now, beta oxidation proper, broadly, you can divide it into 4 steps. First is for oxidation, then a hydration, then again oxidation, and finally the cleavage of the acetyl-CoA, right? So the first step is for oxidation. What we do is we remove the 2 hydrogens from the alpha and the beta position with the help of acyl-CoA dehydrogenase. And who accept this hydrogen? FAD accept this hydrogen, and we have FADH2, right? Then the next step is hydration. We add in a molecule of water in here, right, with the help of the enzyme acyl-CoA hydratase. Thus, a hydroxyl group is present now in the beta position. The next step is again a oxidation, and this time we are removing the hydrogen from the beta position, and we are going to convert it to a keto acyl-CoA, right? And who is going to accept it? NAD is going to accept it. And the last step is the breaking of the beta keto acyl CoA into the acyl CoA and acetyl CoA. This is the acetyl CoA, and this acyl CoA has 2 carbons less than the first one. This cycle keeps on happening till the entire fatty acid is broken down. Right now, let's take the how much ATP is produced. Now, there are 2 concepts for this. This is the old concept, which I would like you not to remember. We will focus only on the first one. And the most common question that is asked is how much energy do you get from the complete oxidation of palmitic acid? Okay, now palmitic acid has 16 carbons. In each of the beta oxidation cycle, we are removing 2. So we require a total of 7 cycles, right? And in each cycle, we are making 1 FADH and 1 NADH. Now, you know that 1 FADH can produce 1.5 ATP and 7 NADH is equivalent to 2.5 ATP. Thus, we get 10.5 and 17.5, right? A total of 8 acetyl CoA, 2 carbon units. So 8 acetyl CoA is there. And this acetyl CoA in the citric acid cycle is converted to 3 NADH, 1 FADH, and 1 GTP, which equals to 10 ATP. So you get 80 ATP. So the total energy that we got from 1 palmitoyl CoA is 108 ATP. But however, we use 2 high energy bonds in the beginning, right? So the net gain is 106 ATPs. So number of ATP formed by oxidation of 1 molecule of palmitic acid is, you're correct, it is 106 ATPs. Now, few clinical correlations with respect to the beta oxidation. Sudden infant death syndrome. What is sudden infant death syndrome? It is the unexpected death of healthy infants, usually overnight. It is due to the deficiency of medium chain acyl CoA dehydrogenase. Glucose is the principal source of energy and soon after eating or feeding of the babies. But after a few hours, the glucose level and its utilization decreases, and the rate of fatty acid oxidation must simultaneously increase to meet the energy needs, which does not happen and leading to the death of the infant. The sudden death in the infant is due to the blockade in the beta oxidation caused by deficiency of medium chain acyl CoA dehydrogenase. Please remember this. The second important clinical correlation is Jamaican vomiting sickness. This disease is characterized by severe hypoglycemia, vomiting, convulsion, coma, and death. And it usually happens by the eating of the unripe ackee fruit, which contains an unusual toxic amino acid called as hypoglycin A. This inhibits the acyl CoA dehydrogenase, the first enzyme in the beta oxidation in the mitochondria, and thus beta oxidation of fatty acid is blocked, leading to various complications. This is just the image of a ackee fruit. Now, let's quickly talk about the other types of oxidation. Oxidation of odd chain fatty acids. Oxidation of odd chain fatty acids is similar to that of even chain fatty acids, but at the end, a 3 carbon unit propionyl CoA is produced along with the acetyl CoA, which are produced in the pre-reactions. So propionyl CoA is converted to succinyl CoA, and succinyl CoA is an intermediate of TCA cycle. The propionyl CoA is gluconeogenic. Acetyl CoA was ketogenic, and propionyl CoA is gluconeogenic. Coming to the alpha oxidation. Now, what is alpha oxidation? It happens in the endoplasmic reticulum, and it is for what? It is for the endoplasmic reticulum and peroxisomes. There are 2 organs in which alpha oxidation takes place: endoplasmic reticulum and peroxisomes, right? And they are for the branch chain fatty acids. For example, phytanic acid, which is derived from the milk and animal fat. So this, in beta oxidation, we started the oxidation at the beta position. Here it starts from the alpha carbon, and 1 carbon at a time is removed. It is important in brain. This branch chain fatty acid does not require any activation, and thus it does not require a coenzyme A, and most importantly, it does not generate energy. Now, let's try to answer a question: which out of the following is not a feature of Cresham's disease? Defect of beta oxidation, defect of alpha oxidation, accumulation of phytanic acid treated by removing phytanic acid precursor from diet. So we know that it is something related to alpha oxidation. It is the accumulation of phytanic acid, and it is treated by removing phytanic acid precursor from the diet. So the correct answer here is beta oxidation. However, let us learn few things about Cresham's disease. It is due to the lack of paroxysmal alpha hydroxylase, or otherwise known as phytonyl CoA hydroxylase. Alpha oxidation does not occur, phytanic acid accumulates, and there are severe neurological problems such as polyneuropathy, nerve deafness, cerebral ataxia. Now, the symptoms is observed with a restricted dietary intake of phytanic acid. Okay, so the correct answer was defect of beta oxidation. The rest all are the features of Refsum's disease. Now, the next question is beta oxidation in peroxisomes generate NADPH, option B H2O2, option C long chain fatty acid, option D FADH2. Now, let's quickly learn about the beta oxidation peroxisomes. The correct answer here is H2O2. Okay, in the peroxisomes, we have the long chain and very long chain fatty acids undergoing beta oxidation, right? It is the second organelle where beta oxidation takes place, and it is usually induced by a high fat diet. Okay. Now, what is Zellweger syndrome? It is the congenital or complete absence of peroxisomes in all tissue. So there is an impaired oxidation of long chain fatty acids. We just now learned that long chain fatty acids are oxidized in the peroxisomes. Thus, there is an accumulation of long chain fatty acid in the brain, liver, and kidney, and thus it is also called as the cerebrohepatorenal syndrome, right? And it is fatal during childhood. So let's try answering a question. Zellweger syndrome is associated with which of the organelles? Lysosome, peroxisome, mitochondria, Golgi apparatus. You are absolutely correct. The correct answer is peroxisomes. So that brings me to the end of today's quick revision on beta oxidation. We have just covered the most important parts of the cycle. Thank you, everyone. You may continue with the next class.
Good evening, everyone. In today's class, we'll discuss about a few important topics related to like basic skin, basic structure of skin and signs in dermatology and phenomena in dermatology. First question: what is the normal thickness of the stratum granulosum? So before before knowing the thickness of stratum granulosum, we should know the layers of skin. First, I'll discuss about the layers of skin. First one is basal layer, which is also called as stratum basale. Second one is stratum spinosum. Third one is stratum granulosum. The name stratum granulosum is because it contains a lot of keratohyalin granules. And the fourth layer is stratum corneum. In some places, in between the stratum corneum and stratum granulosum, what you have an additional layer in palm, especially in palms and soles, you have this additional layer called as stratum lucidum. So this is the layers of skin. Stratum granulosum, they are asking the thickness of the layer. Usually the stratum granulosum is between 3 to 5 layers. If the layer becomes less than 3, it is called as hypogranulosis. And if the layer becomes more than 5, it is called as hypergranulosis. Then we'll see a little about the structure of skin and the cells of epidermis and dermis. In epidermis, you have 4 types of cells. First one is keratinocytes, which are the main cells. Next one is melanocytes. Next one is Langerhans cells. Next one is Merkel cells. These are the 4 cells of epidermis. So in case of keratinocyte, it gives mechanical strength to the epidermis and it is involved in keratinization of epidermis and nucleus of as the cell moves upwards. Here you can appreciate as the cell moves upwards along the layers of epidermis, it tends to lose the nucleus, and this is the process of keratinization. And the keratinocytes, the epidermis is made up of keratin protein. Then the type of protein, keratin protein, which is present in the basal layer of epidermis is 5 and 14, and keratin 1 and 10 is present in suprabasal layers. Apart from this, there is one more protein also, which is present in between the keratinocytes, which helps in holding the keratin filaments together, and that is called as filaggrin protein. Filaggrin protein is very important because in case of filaggrin mutation in atopic dermatitis and ichthyosis vulgaris, we see filaggrin mutation, because of which it leads to scaling all over, diffuse scaling all over the skin. Next cell which is present in the epidermis is melanocytes. These are mainly present in basal layers. As we all know, it gives melanin, it transfers the melanin, it synthesizes and transfers the melanin to the keratinocytes through the dendritic cells. So where it is derived, it is not derived from the skin ectoderm, it is derived from the neural crest layer. And next one is Langerhans cell. Langerhans cells are derived from bone marrow, and this marker for Langerhans cell is CD45, HLA-DR, and CD1A. And Langerhans cell has a typical type of granule in its cytoplasm that is called as Birbeck granules, which is usually tennis packet shape. And the last type of cell which is present in epidermis is Merkel cells. Merkel cells has slow adapting touch receptor cells. Next question. Which of the following protein is not a component of basement membrane zone? Type 4 collagen, elastin, laminin, BP230. If you had listened to my day 1 class where I had explained in detail about basement membrane zone, you would have known the answer for this question. Elastin is the answer. All other type 4 collagen is the basic collagen which is present in the basement membrane, and laminin is also present in the layer of lamina lucida of basement membrane, and BP230 is present in hemidesmosome of basement membrane. So all these are there. Elastin is not there. Elastin is present in the sub basement membrane area, in the dermis only. So here you can appreciate this is basement membrane zone, this is hemidesmosome, this is hemidesmosomes contains BP 230 and 180, and lamina lucida contains BP 180 and laminin. And as I said, type 4 collagen is the main collagen in the basement membrane, which is present in the lamina densa, and the anchoring fibril has type 7 collagen also, and interstitial collagen is here. So this is the basement membrane. Next one, you have to identify the structure. This is the type of gland, one type of gland. This is mainly present in the skin, which is sebaceous gland. Let's discuss about types of gland. In skin, you have 2 to 3 types of gland: sebaceous gland and sweat gland and apocrine gland. So in sebaceous gland, here you can appreciate it's like it is present in and around the associated with the hair follicle, and sweat gland, it will be lying in the deep dermis separately, and you can have acini and secretory tubules in case of sweat glands. And these are the apocrine glands, which will have a bigger lumen compared to the other glands. So these are the types of glands. Next question, identify the process which leads to this cell of this morphology. So this I had discussed the same question in AIMS discussion and INICET discussion and NEET discussion also. This is an acantholytic cell. You should know about acantholysis. Acantholysis, I had clearly explained what is acantholysis already. Acantholysis is due to the loss of separation between keratinocytes due to loss of desmosomes in between the cells. So acantholysis can be of 2 types: primary acantholysis and secondary acantholysis. In primary acantholysis, what happens is the connecting tissue between the 2 keratinocytes, that is the desmosomes, will be damaged, because of which the keratinocyte will be separated from each other. Whereas in case of secondary acantholysis, what you can see is damage occurs primarily to the keratinocytes itself, leads to separation of the keratinocytes from each other. Example for primary acantholysis is all the immunobullous disorders, and apart from that, Hailey-Hailey disease, Darius disease, transient acantholytic dermatosis, also called as Grover's disease, is also an example for primary acantholysis. Whereas herpes simplex virus, herpes zoster, warts, tinea corporis, all these are example for secondary acantholysis. Next question. Desmosomes are helpful in connecting. Again, in basement membrane class, I have mentioned desmosomes are the junctional proteins which connects between two keratinocytes. So this is the answer. And next question, normal turnover time of epidermis. What is the normal turnover time? It is usually 4 weeks. Next one is layer of skin with maximum desmosome interconnection. This you should be knowing. It is nothing but stratum spinosum. And next we will see about basic skin lesions. So you have to identify this skin lesion. Here what you can see is there is some color change definitely, but texture wise there is no change. And so this is a type of lesion which only with color change. Only with color change you can have macule only. So this is a macule. So in patch, this is a circumscribed alteration of skin color of more than 0.5 mm. Whereas in case of macule, you have circumscribed alteration of skin color, which will be less than 0.5 mm. Okay. Then this is a papule, and here you can see papules. So these are all elevation of skin, like elevated skin lesion. In papule, it is less than 0.5, and in nodule, it is more than 0.5. Here, in case of plaque, you can have alteration in the texture of the skin will be there, and the width of the lesion will be more than its height. So this is a typical definition for a plaque and a picture for a plaque. These are the some of the secondary lesion. These evanescent skin lesion is called as elevated evanescent skin lesion is called as wheal, which typically occurs in urticaria. This fluid-filled lesion is called as less than 0.5 mm. It is called as vesicle. The same fluid-filled lesion, if the size is more than 0.5 mm, it is called as bulla. And instead of fluid, if pus is filled in the lesion, it is called as pustule. And this is small hemorrhages, which is called as purpura. So this is all about basic skin lesions, out of which this macule, patch, papule, nodules, plaque, these 5 are primary skin lesions. Wheal, vesicle, bulla, pustule, purpura are secondary skin lesions. And this is also one of the type of secondary skin lesion. Here you can appreciate the skin is little bit atrophied, and you can appreciate pigmentary changes, and there is telangiectasia. You can't appreciate from this. This is called as poikiloderma of civet. Poikiloderma of civet is a type of special secondary lesion where it have a triad of 3 skin changes. It will have atrophy, pigmentary change, and telangiectasias. So next question, identify the skin lesion. What is this? These are closed comedones. Closed comedones is a type of special skin lesion which occurs in case of acne vulgaris. So these are open comedones. Here you can appreciate it. The exposed keratin, the keratin is exposed to the air and it changes color into black color. And this is open comedones. Here you can find some closed comedones. These are called as closed comedones. This is telangiectasia, linear blood vessel. And next question, powdery or briny scales. This I had told in my day before aesthetics class. Powdery scale or briny scale is seen in which condition? This is seen in fever sequela. So we'll see about different types of scales in dermatology. Collarette of scales is characteristically seen in case of pityriasis rosea, where you can see the scales at the periphery of the lesion, like a collar surrounding the lesion. Fusferaceous scale or powdery scales or briny scales. These are the fine loose scales which is present in case of pityriasis versicolor. And usually it won't be visible that much. It may be visible by scratching. If you scratch the lesion, you will have scales. Then that is called as scratch sign or Cope de angle sign. Next is greasy scales. Greasy scale is present in case of seborrheic dermatitis. In case of in scalp, you will find this greasy, oily scales. Ichthyosiform scale is large, polygonal. Ichthyosiform is like fish. The meaning ichthyosiform is called as fish-like. So it is seen in case of Ichthyosis vulgaris. Silvery white scales or fish-like scales is seen in case of psoriasis. Cornflake-like scales is seen in case of pemphigus foliaceus. As we all know, the level of spirit at the for the pemphigus foliaceus is at the level of stratum corneum, so it is very superficial. You won't have intact bullae like pemphigus vulgaris in case of pemphigus foliaceus. So you'll have scaly lesion only. So it will lead to pemphigus foliaceus. What are the important features? Next question: what are the important features of lichenification? In lichenification, again, like poikiloderma of civet, it has triad of 3 findings. You can have thickened skin. Skin thickening will be obviously will be there, and pigmentary changes. Hyperpigmentation and increased skin marking will be there, and this is all of the above is the answer. So here you can appreciate lichenification, skin thickening, hyperpigmentation, and increased skin markings are there. Then apart from that, few other signs, few other important findings in dermatology. Honey-colored crest. Honey-colored crest is seen in case of impetigo. It is impetigo is a cutaneous bacterial skin infection which is caused by Staphylococcus aureus or Streptococcus pyogenes. Hemorrhagic crest is due to this necrosis. So it is seen in case of toxic epidermal necrolysis. Other secondary lesions, apart from what I have discussed till here, is other secondary lesions: excoriation, erosion, and ulcer. Erosion is due to the partial loss of epidermis. Here in ulcer, you will have full loss of epidermis and some part of dermis will be lost. Fissure is linear cut in the skin, and scar is due to trauma or any inflammation which leads to shrinking of skin, and atrophy is due to loss of skin, and induration is also called as thickening of skin. Next question: a 25-year-old female was a known case of psoriasis and had history of trauma 2 weeks back, and she started developing lesion at the site of trauma. And what is the name of this phenomena? Psoriasis patients usually, if they encounter any trauma, they have the tendency to develop lesion at the site of trauma. So this phenomena is called as Koebner's phenomena. As we all know, the other name for Koebner's phenomena is isomorphic phenomena. And some important phenomena in dermatology: Koebner's phenomena, isomorphic phenomena. Apart from psoriasis, other 2 classical conditions which shows this Koebner's phenomena is lichen planus and vitiligo, which can be remembered by the mnemonic LVP: lichen planus, vitiligo, and psoriasis. Apart from this, warts, molluscum also show this pseudo-Koebnerization. Reverse Koebner's phenomena is a type of phenomena in which the lesion will clear after injury. In reverse Koebner's, the lesion will clear after injury. Remote reverse Koebner's is, in some patients, you will have a spontaneous repigmentation in the place distant from the area of trauma. Like it will heal in the area which is very distant from the site of trauma. So this is called as remote reverse Koebner's phenomena. So this is all for today, and I'll continue the class tomorrow with the same topic, phenomena in dermatology. Thank you.
Okay, so welcome back to anesthesia discussion, and we are continuing our discussion on ECG. We are discussing the must-know ECGs for you in NEET PG exam, and we have discussed some around 6 to 7 ECGs, which are very, very important for you in entrance exam yesterday. And this is going to be the continuation of that. So I've given 2 ECGs in this particular frame. Let me make you understand how do you diagnose atrial fibrillation and how do you diagnose atrial flutter in your particular ECG. Okay. Now, see this particular ECG. What is the characteristic feature of this ECG? You're seeing that there is no definite P waves, right? You're seeing that there is no definite P waves. So I can say that the first thing that you're seeing in the ECG, which is mentioned here, is that it has got no P waves. The characteristic feature is absent P waves. This is the first characteristic. And obviously, the second characteristic that you are seeing is, look at the RR interval here. This is one RR interval. This is another RR interval. This is another RR interval. What is the characteristic feature? You're seeing that the RR intervals are literally different. So you're having an irregular rhythm with an absent P wave. If in fact the P wave is replaced by fibrillary waves, this is characteristic of something which is called as atrial fibrillation. So how do you identify atrial fibrillation in an ECG? The most strikeout feature is irregular rhythm, and along with that you are going to get an absent P wave. So I told you yesterday itself, when you are getting an irregular rhythm, you do have 2 diagnoses, which is commonly asked in the exam. The first diagnosis is sinus arrhythmia, and the second diagnosis is atrial fibrillation. How do you differentiate between sinus arrhythmia and atrial fibrillation? You simply look at the presence of P waves. If P waves are present and all P waves are followed by QRS complex, but the RR interval is varying, then it is called as sinus arrhythmia. If the P wave is absent, you are getting a narrow QRS complex, QRS with an irregular rhythm. It is atrial fibrillation. One more important question. The most common cause of irregular rhythm on your ECG is also atrial fibrillation. So the first ECG for the day is complete. Now let us look at the second ECG here. What is the most characteristic feature of this ECG? What do you see here? You are seeing P waves. But what is the morphology of P waves? The morphology of P waves has got a very characteristic sawtooth appearance. It has got a sawtooth appearance. So when you are having a morphology of P waves, which has got a sawtooth appearance, it is generally something which is called as atrial flutter. So this ECG is characteristic of atrial flutter. So you can see the sawtooth appearance of P waves here, just like this. Okay, so this is characteristic of atrial fibrillation. One more important question that you might have from your atrial flutter is, how do you one very important question that you might be associated with atrial flutter is, when you are having atrial flutter, there will be associated AV block, because generally the atrial flutter, the rate is going to be more than 220. I'm talking about atrial rate, not ventricular rate. So when the atrial rate is more than 220, obviously you do understand that all of it cannot be conducted to the ventricles. So it will be associated with the classic physiological block. Now let us examine here. What you see here is, you are seeing a QRS complex, and immediately following a QRS complex, you are seeing an inverted P wave. Then you are seeing 3 P waves, following which you are getting a QRS complex. So what I would like to tell here is, this particular atrial flutter is associated with a physiological block of 3:1. So how do you diagnose this atrial flutter? You will diagnose this atrial flutter as atrial flutter with a physiological block of 3:1. Please do remember that physiological AV block is mandatorily present in all atrial flutter cases, because generally the atrial flutter rate is more than 220, or the atrial rate is more than 220 in your atrial flutter. Okay. Yeah. So this is the second rhythm that you are seeing here. What is the characteristic feature here? I just want you to read it as PQRST, PQRST, PQRST. That is all what I want to do. So say, imagine I'm talking about this particular QRS complex. I know that this is QRS Following QRS, what do I have? I have something which is called as T wave. In this particular patient, the T wave is inverted. Let it be inverted. I'm not talking about anything else other than the rhythm, right? So QRS T. And following the T, you are getting a positive wave, and obviously this is your P wave. And following the P wave, you can see that there is almost two small big squares, following which you are getting a QRS complex. So again, this is QRST, and again you are getting a P here. Following the P, you are getting two big squares, following which you are getting QRS complex. So what I would like to tell you is the PR interval is actually almost two big squares in this patient. What are the characteristics that you are able to observe in this particular ECG? All P waves are followed by QRS complexes, but the difference or the distance between the P wave and QRS complex is markedly increased. It is about two big squares. You know that. What do you mean by PR interval? The PR interval is the distance between the beginning of your QRS P wave up to the beginning of your QRS complex. Generally, the normal duration of your QRS complex is between 0.12 seconds to 0.2 seconds, which means the maximum duration your PR interval can have is one small square. If it is more than one small square, you call it as prolonged PR interval. So what are you exactly observing in this ECG? In this ECG, what are you seeing is you are getting a PQRS relationship which is maintained, but consistently the PR interval is around two boxes, which is around 0.4 seconds. For every P wave, you are getting a QRS complex and the duration of PR interval has prolonged. So what is this condition called as? This condition is what is called as first degree AV block, where there is only prolonged PR interval, but there is no skipped beat or there is no intermittent beat. First degree AV block means there is only prolongation of PR interval. So this is an example of a hard block. Sorry. This is an example of, one second. This is an example of hard block where you are getting prolonged PR interval, but all P waves are followed by QRS complexes, right? So this is first degree AV block. Okay, this is first degree AV block. Now let me take you to the next ECG. What are you seeing here? Again, look at the PQRS relationship. Start from the beginning. This is the first PQRS relationship. This is the second PQRS relationship. This is the third PQRS relationship. And now look at the fourth. What are you seeing? The PR interval is relatively normal or short here, and then it is slightly progressing. And again, there is a progression of PR interval. Finally, you are getting a P wave, but that P wave is not followed by a QRS complex. So what is this? What is this you are exactly observing? You are getting progressive. You are getting progressive prolongation of PR interval. Progressive prolongation of PR interval followed by a missed beat, right? Missed beat. So what are you observing here in this ECG? See, this is PQRS, 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 and after a P, you are missing a QRS complex here. Again, a P is starting, and again, prolongation is happening. So progressive prolongation of PR interval, finally culminating in a dropped beat or a missed beat. This is what you are seeing, yes or no? And this phenomenon is what is called as Wenckebach's phenomenon. This phenomenon is what is called as Wenckebach's phenomenon, or otherwise called as second degree hard block. Second degree hard block, Mobitz type 1. Mobitz type 1. So this is what you are exactly seeing in this particular ECG. This is a very, very classical ECG. And among the AV blocks which could be asked for you, the most common AV block that can be asked for you in an entrance exam is Wenckebach phenomenon or type 2 Mobitz block. Okay. Sorry, type 1 Mobitz block. Okay. So this is the most difficult of all the AV blocks for you to identify. Okay. I'll tell you why. You are seeing a QRS complex here. You are seeing a P wave here. You are seeing a P wave here, following which you are again seeing a QRS complex. What is this? This is again P wave. This is again P wave. There must be a P wave here. You are not really able to see because it is submerged inside the P wave. This is P wave, and again this is P wave. So what are you seeing? You're seeing that P waves are happening at regular intervals. Yes or no? And you're also noting that QRS is also happening at regular intervals. If you look at the RR interval, I can count here 1, 2, 3, 4, 5, 6, 7. So it is similar here. The RR interval is similar. The PP interval is similar, but there is no relationship between the P wave and the QRS wave, right? You can see that there is no P wave proceeding here. There is a P wave which is proceeding here. Again, no P wave is present just prior to this QRS complex. So what I would like to tell you about this particular ECG is that there is P wave, there is QRS complex, but the PP interval is maintained, the RR interval is maintained, but there is no relationship between P and QRS, right? So let me write down the features of this particular ECG. First, the PP interval is maintained, which means atria is contracting at a regular interval. Second important factor is the RR interval is maintained, which means that there is a ventricular contraction which is happening at a regular rate. But the most characteristic feature is that there is no relationship between the P wave and the QRS wave. It is absolutely not maintained. So there is no relationship between P and the QRS wave. So it essentially means that this is what is called as atrioventricular dissociation, where atria contracts on its own and ventricle contracts on its own, but there is no relationship between atrial contraction and ventricular contraction. So this is third degree AV block. This is third degree AV block. Okay, so this is a very, very classical ECG. It might be initially very, very difficult for you to identify, but when you get a picture like this where the heart rate is very, very low, you look at the PP relationship and QRS to QRS relationship. It is very, very mandatory. Okay, now let me just summarize the blocks here. So when you are talking about AV blocks, AV blocks are divided into three: first degree AV block, second degree AV block, and third degree AV block. What is the characteristic feature of first degree AV block? The characteristic of first degree AV block is that there is only prolongation of QRS complex, PR interval, but the PQRST relationship is maintained. Okay, so which means that this relationship is maintained. For every P wave, you will have a QRS complex, but the interval is prolonged. You please do remember that a normal PR interval is around 0.12 to 0.2 seconds. So when the PR interval is more than 0.2 seconds, which essentially means one big square, it is called as prolonged PR interval. So when you are getting a prolonged PR interval and when all P waves are followed by a QRS complex, it is called as first degree heart block. So when it comes to second degree heart block, your second degree heart block is again divided into two: Mobitz type 1 and Mobitz type 2. What do you mean by Mobitz type 1? Mobitz type 1 essentially means it is Wenke-Bach phenomenon, where there is progressive prolongation of PR interval, finally culminating in a dropped beat. Now imagine that this is a P wave and this is a QRS complex and this is T wave. Now again you are going to have a P wave, but now you are going to have a prolonged PR interval, slightly prolonged here, and then again you are going to be getting a T wave. Again a P wave, increased PR interval and a T wave, again a T wave. Then you get a P wave and a missed beat. Finally, you are again getting a P wave. So you can see there is progressive prolongation of PR interval. There is progressive prolongation of PR interval, finally culminating in a missed ventricular beat. This is what is called as Wenke-Bach phenomenon or Mobitz type 1. What do you mean by Mobitz type 2? In Mobitz type 2, there is nothing, but there is a fixed relationship between the missed beats. For example, this is P QRST, this is P QRST, then you are getting a P and a missed beat and again P QRST. So for every two P waves, you are getting a missed beat. So this is 2:1 block. Sometimes you can get P QRST, P QRST, P, and again a missed, again a P QRST. So this is 3:1 block. So you lose a beat at fixed intervals. It is called as Mobitz type 2. If there is progressive prolongation of PR interval, finally culminating in a missed beat, it is called as second degree heart block. Okay, and what do you mean by third degree heart block? It is otherwise called as atrioventricular dissociation, where there is no relationship between the P and QRS complexes. You get a regular PP interval, you get a regular RR interval, like what I just showed you in this particular image. Right. Like in this particular image, you can see that there is P here, P here, P here, P here. So generally you are getting a regular PP interval, you are getting a regular RR interval, but there is no PQRS relationship, which means atria is contracting on its own, ventricle is contracting on its own, but there is no relationship between atrial contraction and ventricular contraction. So this is third degree heart block. So this is the culmination of our discussion on ECG rhythms. I've discussed almost every rhythm which could be possibly be asked in your exam, starting from your arrhythmias, tachyarrhythmias, bradyarrhythmias, and AV blocks. And we have something slightly left behind, which is your ST elevation MI and non-ST elevation MI, and certain conditions like bigeminy, trigeminy, and your and ST elevation MIs and non-ST elevation MIs. That is the only thing which is left behind for our discussion on ECG. But I expect questions to be asked from these rhythms for your INICET exam. I hope you enjoy this discussion. I'll bring a new topic again next Monday. Have a good night. I hope you enjoyed this topic. Thank you.
I welcome all of you for today's session on expected questions for INICET and NEET SS upcoming exams, and also NEET PG upcoming exams. Male smoker presents with claudication pain on the right thigh. Angiography was shown. Of course, the picture is not here. And what will be the next management? So it's a claudication on the right side. It's on the right side pathology. So there's going to be an obstruction. That's the reason why the claudication pain is on the right leg. And so what would be the next management of choice for this patient? So iliofemoral graft, iliofemoral graft, endovascular stenting, all of the above. So the right answer is endovascular stenting. And unfortunately, we don't have a picture of that. And so you can see the classification of peripheral arterial disease based on Fontaine and Rutherford classification. Now, when you see asymptomatic of Fontaine is 1, mild claudication is 2A, moderate to severe claudication is 2B, and 3 is ischemia, rest pain, and 4 is ulceration or gangrene. Now, let us come to the point here. Now, when there is a question like this, and probably, this patient could have a block at the iliofemoral area, and the best, so this could be the aorta, right common iliac, left common iliac, and internal iliac, external iliac, correct? So this is external iliac and this is internal iliac. Internal iliac, external iliac, continuous as femoral, internal iliac. Understood? Clear? Now, what you need to understand is, if there is a block, okay, suppose on right side, so this is right and this is left. So if there is a block on the right side, you can plan for dilatation and stenting here. Now, if suppose stenting and endovascular facilities are not available, okay, then the best choice would be the best choice would be for an iliac obstruction, unilateral iliac obstruction. You will plan for femoro-femoral crossover graft. So you will plan for femoro-femoral crossover graft. Femoro-femoral. If suppose the block is at the bifurcation, it involves both the iliacs, right and left. Okay, then the graft of choice. So external iliac continuous as femoral. So this will be the femoral artery and femoral artery here. Now, what will be the choice in case of lyrics? Bilateral iliac. This is called bilateral iliac obstruction. What would be the choice? The choice of graft will be ioto-bifemoral grafting, like a trouser graft. Okay. So this is ioto-bifemoral grafting. Ioto-bifemoral grafting. If ioto-bifemoral grafting is not possible, then you can plan for axillo-bifemoral grafting. Understood? So first step, you will see the block is bilateral, then you go for ioto-bifemoral. If not possible, axillo-bifemoral. If it is going to be unilateral, then you're going to for femoro-femoral crossover. What if there is an obstruction in the femoral artery? See, the femoral artery continuous as popliteal artery, and popliteal artery divides into the anterior tibial and the posterior tibial, right? So this is femoral artery, this is popliteal artery, this will be anterior tibial artery and posterior tibial artery. You suppose there is a block here in the femoral. Then what you can do is proximal to the block and anastomosis distal to the block. So this bypass is called femoro-popliteal bypass. It's called fem-pop bypass. Femoro-popliteal bypass. If suppose there is a block at the level of popliteal artery, then what you can do is you can plan for a femoro-distal bypass. See that? Femoro-distal bypass. Understood? Any bypass in the anterior tibial or the posterior tibial are not yielding that great results. You can do a percutaneous balloon angioplasty. Okay. So for anterior tibial or posterior tibial, it can be involved in Berger's disease, TAO, thromboangiitis obliterans. You can do a balloon dilatation and abstinence from smoking. If it's going to be diabetic, strict control of glycemic control is required. And these are the various levels where you can be able to do a intervention. Okay. So you can see very clearly block at the common iliac, on both the common iliacs, ioto-bifemoral, unilateral iliac, femoro-femoral crossover. If it is going to be femoral artery obstruction, femoro-popliteal bypass. If it's going to be popliteal artery obstruction, femoro-distal bypass. So these are the possible bypasses that can be used, and the graft of choice. The graft of choice is saphenous vein graft and reverse saphenous vein graft. If you want to use in situ, then you have to use valvulotome. That means you need to break the valves. It's called valvulotome. Understood? Or the synthetic graft is PTFE graft, polytetrafluoroethylene graft, PTFE graft. For all infrainguinal bypass, we'll use PTFE graft. If you want to use a PTFE graft across the joint, especially the knee joint, then you will use ringed PTFE graft. Ringed PTFE graft. Understood? So all this are very, very important for you to understand and know. And so the peripheral vascular disease can be because of diabetic atherosclerotic type of disease or occlusion, or it could be because of TAO, thromboangiitis obliterans or Burgess disease. Understood? I think things are very clear for you, and hopefully you would have read now the Fontaine classification also, and very, very important for exam. Now let us go through Schwartz 11th edition, page number 9, 54 and 55. What is given? The potential to reduce the mortality and morbidity while achieving the limb salvage is the impetus that makes the thrombolysis preferable to open surgery. The first line of treatment of patients, okay, acute limb ischemia, class 1 and 2A. Yes, the advantage is thrombolytic therapy over a balloon embolectomy, include the reduced endothelial trauma and potential for more gradual and complete clot lysis in the branch vessels, and usually too small to access by embolectomy balloons. Okay, so it's very, very clear. It's mainly first order is going to be balloon dilatation and stenting would be the first order of choice among the options given here. Then if it is not okay and it's going to fail, and then probably you will be able to use the formal surgical bypass techniques. Hope things are very clear to you, and definitely you will learn a lot by joining SPEED. I welcome all of you to SPEED Institute to use SPEED Learning app and to enjoy each and every sessions taken by wonderful set of faculties of SPEED. Welcome once again. Thank you very much for being with us. Yeah.